Good morning, guys.
Good morning.
Morning.
I forgot my computer at the RVH, so I'm going to be on my phone for most of it, and I'll drive during the meeting to get my computer. Hopefully it doesn't mess things up. Oh, Dana,
Yeah.
just to make sure that when I drive to go get my computer, because that's kind of stressful to have left it there, I'm going to make you co-host, okay?
Why?
Why? Well, because Jake is not here this morning, so I need somebody to be co-host. It's okay. You don't have to actually be co-host, but if something goes wrong, then you're gonna
Yeah.
be there, and I'm gonna do that on the link. So if something happens with mine, then the link stays open.
Okay, but I need to go to Hamda's house because we're gonna do the presentation together. So when are you going? So
Now I'm gonna be going once the presentation starts.
okay, I'll figure it out. I'll keep it on my phone then, the hosting.
Okay.
Okay. I'm already signed in on my phone because I was post evening shift. So.
Okay. Well, maybe Estebra.
It's fine. I can do it.
Yeah. Okay.
Yeah, don't worry.
So I'm putting you co-host, so that
Sure.
should prevent some issues, hopefully. I did have a bit of a freak out 5 minutes ago when I couldn't find my computer. I'm like, I need to go get it back.
Yeah, that's a big thing to lose.
Yeah. Guys, it looks like people are logging in super slowly this morning, so let's give it until 8:05, okay?
Perfect.
Schedule is pretty packed this morning, guys. So what we're gonna do is at 8:05 sharp, we're gonna be starting, okay? By this time, hopefully more people have logged in. Fad, Mazoud, and Humaid, whoever is starting, do you guys want to start sharing your screen to make sure that we troubleshoot for any problem?
Yeah, can you please share
Good
screen?
morning.
Hey, morning. Can you please share screen to Mazoon? I think she's there, right? Yeah.
She should be able to. Hi, Mazoud.
Yeah, good morning.
Surviving ICU?
Yes. Okay.
Okay, guys, I think you could actually get started. We're starting to get good numbers. It's 8:03. It's quite packed this morning. So morning to all. Welcome to Rounds again. We have a first presentation, which is a journal club. Mazoon, Humaid, and Fad will be presenting to us about the paramedic trial. You guys go ahead.
Thank you, Anne-Sophie. Hello, everyone, and welcome to our journal club. Today, Mazoon, Humaid, and I will present a really interesting, relevant, and high-impact article in the field of emergency medicine. Let's start. So over to Mazoon.
Good morning, everyone. Today we will be talking about an article that was published in the New England Journal of Medicine in 2018. It's titled Paramedic for short, or for long, the pre-hospital assessment. Sorry, I'm very, very sorry.
No worries, take your time.
Okay. This is the only mistake, I promise. Okay. In short, paramedic 2, or in long, pre-hospital assessment of the role of adrenaline, measuring the effectiveness of drug administration in cardiac arrest. It's a randomized trial about the epinephrine use in out-of-hospital cardiac arrest. Our outline is, first, we're going to talk about why is this topic important, the hypothesis or the question that's being asked. I'll talk about the methodology and study design. My colleagues will continue talking about the results analysis, the conclusions, and then finally we have our evidence-based medicine, the survival analysis. So why is this topic important to us? As we all know, cardiovascular disease is listed by the WHO as the leading cause of death globally. According to the American Heart Association in 2019, one person dies every 40 seconds from heart conditions in the United States. The latest statistics in Canada that I was able to find were in 2016, and they were as follows. 9 out of 10 persons in Canada have at least one risk factor for heart condition. One person dies in Canada every 5 minutes from heart condition, stroke, or vascular cognitive impairment. So it's a significant burden. And how does that translate to us? For us emergency medical workers in the treatment of cardiac arrest, we have few effective strategies. Out of the 2 interventions that have shown survival with a good neurologic outcome are early initiation of CPR and prompt defibrillation of a shockable rhythm, which already are parts of our ACLS algorithm. Another part of our algorithm is epinephrine or adrenaline, which is actually beneficial in cardiac arrest because we take advantage of its action on the alpha adrenergic receptors. It increases the peripheral vasoconstriction, which in turn increases the aortic diastolic pressure, which allows more blood flow to go through the coronary and cerebral blood vessels during CPR, which maximizes your chances of achieving ROSC. However, the other detrimental effects of epinephrine are mediated through its action on the beta adrenergic receptors, especially on the myocardium, because of its ionotropic and chronotropic effect on the heart. It increases the myocardial oxygen demand and also decreases the microcirculation, which in turn leads to fatal arrhythmias, cardiac arrest, and a worse neurologic outcome. So there was always this debate or ambiguity regarding the safety and efficacy of epinephrine in use of cardiac arrest. What does our previous literature review tell us? In 2011, Jacobs was a double-blinded, placebo-controlled randomized trial that looked at the effects of epinephrine on survival in out-of-hospital cardiac arrest. And the results showed that the patients receiving adrenaline during cardiac arrest had no statistically significant improvement in survival to hospital discharge, although there was significant improved likelihood of achieving ROSC. Of note, that was the largest randomized controlled trial on the use of epinephrine at that time. However, it ended prior to complete enrollment. In 2014, a systematic review and a meta-analysis of randomized controlled trials looked at the efficacy of epinephrine in out-of-hospital cardiac arrest administration, concluded that no benefit of adrenaline in survival to discharge or neurologic outcome, and administration of adrenaline to hospital discharge or neurologic outcome. However, there was improved rates of survival to admission and achieving ROSC. So again, our literature review is still ambiguous regarding the efficacy of epinephrine in out-of-hospital cardiac arrest. So the question is epinephrine safe and effective as a treatment in out-of-hospital cardiac arrest? We are going to dissect this article to answer this question. Our summarized PICO for our population of interest is we have 8,014 adults who sustained out-of-hospital cardiac arrest. Our intervention group received 1 milligram of epinephrine compared to the placebo or control group, which received 0.9% of normal saline. And the primary outcome that they measured was survival at 30 days. And now I will go into the details. The aim of this study was to assess the use of epinephrine as a treatment in out-of-hospital cardiac arrest. Our study was a multi-center, randomized, double-blinded, placebo-controlled trial. It included 8,014 patients who sustained out-of-hospital cardiac arrest. It took place in the United Kingdom between the years of 2014 to 2017. And because cardiac arrest is life-threatening, informed consent was deferred in accordance with the European legislation until the actual emergency has passed. So for our population, any adult who sustained out-of-hospital cardiac arrest for which advanced cardiopulmonary life support was provided by trial-trained paramedics were eligible for inclusion. It's also worthy to mention that the patient's characteristics were well balanced at baseline. Now, they actually excluded any patients that were pregnant, age 16 years or less, cardiac arrest due to asthma or anaphylaxis, if the patients received administration before the arrival of the trial-trained paramedics, and one ambulance service excluded traumatic cardiac arrest. Okay. Now, if the initial attempts of the CPR and the defibrillation were unsuccessful, the patients were randomly assigned to receive either parenteral 1 milligram of epinephrine or 0.9% saline, which were the placebo group. So the patients were identified as having a cardiac arrest, the ambulance was called, and then the ambulance would arrive to the patient. The median time of arrival would be 6 minutes. The median time to drug administration was 21 minutes. Uniquely numbered, but identical appearing trial packs containing they had 10 pre-filled syringes of either 1 milligram epinephrine or 0.9% of normal saline. A single dose of the agent or either agent was given via IV or IO access every 3 to 5 minutes following the ACLS algorithm. The randomization sequence was computer generated with an overall assignment ratio of 1:1. And the treatments were continued until either ROSC was achieved or resuscitation was terminated. However, no further details were mentioned on why would this resuscitation be terminated, or the care was handed over to a clinician at the hospital. The outcome. The primary outcome that was measured was survival at 30 days. They measured multiple secondary outcomes. Most importantly was survival to hospital discharge with a favorable neurologic outcome. They also looked at survival until hospital admission, the length of hospital admission, the length of ICU stay, survival at hospital discharge at 3 months, and the neurologic outcome at 3 months. And they measured their neurologic outcome on a modified Rankin scale. On a modified Rankin scale, which measures the degree of disability and dependence in the daily activities of people who have had stroke or vascular cognitive impairment. 0 being no deficit at all, and 5 having severe disability, and 6 is death. So a favorable neurologic outcome was identified of scores 3 or less on the modified Rankin scale. Now over to my colleague Hamid for the results.
Thank you, Mizoun. So we'll speak now about the results and what's about the primary outcome and secondary outcome. As we see the primary outcome is the survival, the 30-day survival. It was increased with the EBI group, and the author has many secondary outcomes. So there was more ROSC in the field with the EBI group, more patients admitted with the EBI group, no difference length in the stay in the ICU and the hospital, slight increase in survival until the hospital discharge with the EBI group, slight increase in survival at 3 months with EBI group, and no difference in neurological favorable survival at hospital discharge. And the last thing is about the favorable neurological outcome. It was worth at 3 months with the EBI group. So among this all primary and secondary outcomes, it was the most 2 important points is there is increase with the survival rate in the 30 days, but there was worse favorable neurological outcomes at 3 months with the EBI group also. So what's the author concluded from his question? So the pre-hospital use of epinephrine in the patient with out-of-hospital cardiac arrest and resulted in significantly higher rate of survival rate at 30 days compared to the placebo. but there was no difference between the group regarding the favorable neurological outcomes. However, there's more survivor with epi group had more severe neurological outcome. So we'll discuss now about what's the strength and the limitation of the study. The author, yes, asked a clinically important question. The study, it is a large study, multi-center, double-blinded, placebo trial control, well-balanced and patient characteristic. There was some data regarding quality of the CPR was documented when it was available. They recorded a serious adverse events, and there was a follow-up like regarding 3 months after the discharges to see like the neurological outcomes. And the limitation, so the time of administration of epinephrine, it was 21 minutes, which that time could the patient like turn to the acidotic status, which might kind of decrease the efficacy of the epinephrine. And the dose, it was 1 milligram. It might like they change the dose from like 1 milligram to other like higher dose. It could also change the result. The second point is there was no data and patient baseline neurological status, which might also change the result of the study. If we know some like the baseline of the patient, some of them may have some already the neurological disability. So with the survival and increase like worse, the favorable neurological outcome could be different. And the quality of the CPR, yes, it was one of the strength, but unfortunately it was only in the first 5 minutes and less than 5% of the patient. So what we concluded from this study, the epinephrine group, yes, it's improved the 30-day mortality, but it might be at the cost of the worst neurological outcome. Now I'm going to turn to the Fahad to speak about the evidence-based topic. Thank you.
Okay, now we will move to our last section of Journal Club, which is about survival analysis. Here are the outlines of survival analysis. So what is, so it's a brief highlight of randomized controlled trial, introduction to a medical survival analysis. What is censoring? Some definition and terminologies, and understanding and interpreting Kaplan-Meier curves. So as you see in this slide, we are revisiting how to design a randomized controlled trial. As you see in this illustration, we have our target population, randomly assigned to treatment and control. With time, we will achieve the outcome. So a randomized controlled trial is a study design that randomly assigns participants into an intervention group or a control group. So to define survival analysis, it's a statistical method for studying the time to an event. The term survival suggests that the event of interest is death, but the statistical technique is useful for other types of events, and it can be used in cohort or randomized controlled trial. Other examples: time to death, time to onset relapse of disease, length of stay in hospital, and may include onset of illness, injury, recovery from illness. And as you see here, it's a binary variables, which only takes 2 values, true or false, and yes or no. So time of an event, that's the survival analysis. And it's a method for analyzing longitudinal data on the occurrence of an event. Some other terminologies, and we just spoke about the time of event, which is the time from entry into the study until a subject has a particular outcome. And then censoring, which defined as subjects are said to be censored if they are lost to follow-up or drop out of the study, or if the study ends before having an outcome of interest. And now in the next slide, we're gonna see an example of censoring. So in this example, as you see here, there are students, terms, and outcome, and the outcome, which is graduation. So student cohort, total number of 5. Event of interest is graduation. As you see, there are student 1, 2, 3, 4, and 5. Student 1 drop after term 5, so graduation status 0. Student 2 within 9 terms graduated. Student 3, 14 terms and still ongoing study, so did not achieve outcome. And student 4, 5 graduated. So as shown, total participants of 5. 2 are censored, student 1 and student 3. Event of interest was achieved in student 2, 4, and 5. And now we're going to move our talk to Kaplan-Meier curve, which is one of the most frequently used methods of survival analysis and estimates the likelihood of survival, assumes that those censored would have had similar outcomes. So Kaplan-Meier estimate is a survival function estimator. And as you see here in the figure in the graph, there is an overview of how data is represented on the Kaplan-Meier curve. So in this figure, y-axis is survivors per percentage, 100%. X-axis is time, and it shows what's the probability of an event, for example, survival is at certain time of interval. A participant's experience. So in this figure, a participant experiences an event. Every time an event occurs, a survival probability drops of the remaining curve until it reaches 0 at the end of the study. We'll go into another example of how Kaplan-Meier curve illustrated, and that's my last slides explaining of how is the Kaplan-Meier curve. Again, as illustrated and it's shown at red dots, you see timing of deaths in 4 subjects, 0.8, 3.1, 5.4, and 9 months. And if we want to see the censorship and timing of loss to follow-up, as shown in green vertical lines, 1, 2.7, 7.0, 12.1. And again, in red dots, these are the outcome. So that's would conclude our talk. Here are the references, and thank you, everyone. And if you have any question or comments, we'll be happy to answer.
Great, thank you, guys. Do you have any questions? Okay, I think you guys were clear enough. We're a bit before time, but that's good. Dr. Suthan, would you be ready to start your presentation by any chance?
Hello, yes. Good morning.
Yes, hi. Good morning.
Hi.
Thank you for being here this morning. I know I was a bit last minute. We really appreciate it.
Okay, it's very early than I thought. So
Yes, same here.
That's good, and thank you for sharing about the article. It's very good. So okay, let me share my screen first. And okay. Now, can you see my screen?
Yes, all working well.
Okay. Good
Floor is
morning,
yours.
everyone.
Thank
And
you.
again, my name is okay. My name's my name's Krongan Sutham. I'm the fellow of the emergency ultrasound. And as you know, I'm here to train about the emergency ultrasound program or POCUS. So today I'm going to present some cases that I use ultrasound to evaluate my patient at the bedside. So before I share my cases, I'd like everyone to start with a quick quiz, and it's going to be fun. You have only 10 seconds per image because you're emergency physician, right? You have to answer the question with a one best choice. You have to select one best choice, yes or no or not sure. It's very easy, right? And the time will not stop until 1 minute has passed. So you can write your answer down on your or note, and please send it to me in the comments or once you have complete or 6 cases. Okay, are you ready? Okay, let's go for the first one. Okay. Second, sorry. Then the third one. Then question 4. Just yes, no, or not sure. For 5. And the last one. Okay, it's very fast, right? Let's go back to our emergency department. All of the answer will be available on my today cases. So today, this is the emergency department cases. They are all presented with the chief complaint of pain. I will start with the first one. He is 31 years old male, presents with epigastric pain for 3 days ago. His vital signs very stable. For the patients present with the acute abdominal pain, I always use the ultrasound to take a look on the belly to see if there are any free fluid on in intraperitoneal cavity in the supine position. And from these 2 images on the right and the left upper quadrant, this is the caudal tip and this is the interface. Okay, so do you see any free fluid? No, it's very easy, right? Okay, no free fluid on both left and right upper quadrant. Please make sure that you see through the caudal tip of the liver and the spleen. Okay, this is what I saw while I using the ultrasound to scan on the right upper quadrant of the patient from the medial to the lateral side like this. Okay, and this is another view of the right upper quadrant. What are you seeing? Is there anyone want to answer for this question? Is there any pathology on this view?
I can't, maybe I see some sort of shadowing, but I'm not sure if there is any stones or not, but shadowing might represent like some pathology there.
Thank you so much, Dr. Fall. Okay, I stopped the clip and this show the classic finding of war echo shadow sign, okay, which include of three lines. The first one is a hyperechoic line, right? The second one is a hypoechoic line. And the third one, again, hyper or bright echoic line, and with a posterior acoustic shadow. So, okay, it's again called the wall echo shadow sign. So this is very classic ultrasound finding in the gallbladder, gallstone. We can see this sign within the gall bladder fossa, referring to the appearance of the stone inside the gallbladder. So for this sign, it's including of 3 lines with 1 shadow. So now you can see this is the first one is represent the gallbladder wall, and the second one is the black line represents a small amount of bile or fluid inside the gallbladder, and the last one is hyperechogenic line, represents the near surface of the gallstone. So it means the gallbladder is not distended, it's contract and very close to the gallstone. So it's very hard. You have to careful carefully take a look on that. And this because it's the lash of the gallstone, so you can see the posterior acoustic shadows. That is very important artifact of the stone. So this sign suggests either large gallstone or multiple small gallstone filling the lumen of a contract or incompletely visualized gallbladder. Okay, recognizing this size will help us to aware of the bowel loop or the gallstone. You have to differentiate from that. So get back again to our case. The last view of entire abdominal cavity is the suprapubic area, and there's no free fluid on the suprapubic region. For this case, this patient has previously multiple episodes of admission of pancreatitis. He had significant elevated amylase enzyme on this admission. So this is my POCUS finding, and I suggest that this patient may have recurrent pancreatitis with gallstone. And these are my treatment plan. I give him IV fluid and consult surgery, who's need the official report from the formal ultrasound. So this is the formal ultrasound report that there's non-distended gallbladder contains innumerable tiny gallstone and no signs of cholecystitis. There's a simple cyst on the right kidney, which is very common to see in the normal population, as you know. This patient has been admitted in surgery ward and underwent the operation of laparoscopic cholecystectomy. Here can discharge home without any complication. Okay, and although the ultrasound does not replace CT scan or MRI in the diagnosis or evaluation of the pancreatitis or any complication, this is the primary role of the ultrasound, that it can identify the gallstone or signs of biliary tract obstruction, and it is also possible to access some complication of those patients who in the appropriate setting. So for me, Barry used the ultrasound to see the pancreas directly, but we can see the secondary sign or the course of pancreatitis like the gallstone, because it's very common. Okay, for the first answer. So now you know that is the war echo shadow side, right? In the right upper quadrant. So you're gonna be say yes. Okay, so I move to the next patient. He's an elderly, 89 years old male, present with acute abdominal pain for 5 hours ago. His vital signs stable, he has no fever, and yes, again, I always take a look on both upper quadrants, and this is the interface of the right kidney, the left kidney, and this is the caudal tip of the liver and the caudal tip of the spleen. Okay. Right, take a look carefully, and yes, no obvious free fluid. Everyone know. Okay. Wire screen on the right upper quadrant and scan through like on the right side of the flank and downward to right lower quadrant. Right here is. There anyone know, is there any abnormality on this wheel? Anyone have
It looks like there's free fluid.
Okay, thank you so much. Could you please say where is the free fluid?
Sorry, my camera's on. This is in the bladder, right? This is your pelvic view, is that correct?
Okay, this is my probe, and I put the probe on the scan through the right upper, through the right lower quadrant. In the
it looks like it's in between bowel, or is that a sign of bowel perforation? Could you see that on the ultrasound?
Okay, thank you so much. Okay, this is you can see it looks like the free fluid, but it's not the free fluid, right? Because in the fluid it inside the bowel is it's a contained fluid. So is the fluid inside the bowel, and you can see it's multiple bowel loop dilatation, right? So from this caliper, you can see it's around 3 centimeters or more than that. Okay, I will show you another picture. Okay. This is the bowel, and do you know what is it? It is plica circularis, or we can call it a bowel conniventis. So it is the characteristic of the small bowel. So these are the small bowel loop dilatation, and you can see the inside there's some fluid and bowel content, and it's moved through and fro movement like this, according to the peristaltic bowel. And okay, this side is very important to diagnose of the small bowel obstruction, because the large bowel never present like this. The small bowel can have this side we call piano keyboard side, which is it look like the keyboard. You can see the white one and switch with the black one, right? And it's appear right the black and white keys of the piano. So you can call the piano keyboard side, which represents small bowel or jejunum. Actually, they are for the large bowel, we never seen the side like this. So it's very important to know that. So for this, you can see the jejunum is dilatation, the peristaltic to and fro movement inside the bowel, and because it's dilatation, so we have to make sure that it's dilate constantly or not. So I use my probe to compress on the bowel, and it seems like we cannot compress that bowel. So there's another image that I use the probe to see the bowel again, and it's significant dilatation, non-compressible bowel dilatation. And for the diameter of the bowel, I measured it, and the maximum diameter of the bowel is around 4 centimeters. Okay. Do you know the maximum diameter of the small bowel? It should not more than 2.5 centimeters. Okay. So these are the findings from my POCUS. The small bowel dilatation is more than 2.5 centimeters. There's free fluid. Sorry. There's no obvious free fluid, but there's some fluid-filled loop of peristaltic bowel, which dilated, and there's to and fro motion inside. So it is the classic finding of the small bowel obstruction. So I saw this from the bedside, and this is my treatment plan. This is a patient who's known for remote, to have remote appendectomy and has laparoscopic hernia repair, and he presents with small bowel obstruction. And with the formal CT scan on his abdomen, it's confirmed that he had a small bowel obstruction from the adhesion inside his belly. Okay, and the plan is I put we give him an NPO and consult surgery. He was admitted to a surgery ward and has non-operative management. And okay, so this is very classic, and as you know, why if you see only one case, you can remember that well. For me, I never used ultrasound to detect any small bowel obstruction before I came here. So I reviewed some evidence, and on the current evidence of the systematic review, it's very wonderful tool for identifying small bowel obstruction for the POCUS. And you can see the from this finding of the diagnostic accuracy of the POCUS, why seeing small bowel obstruction is very good with a high sense, high spec, and very high likelihood ratio. Okay. In my country, I'm from Thailand, I always use abdominal plain film X-ray to diagnose of small bowel obstruction, which are very low, very low performance in accuracy in diagnosis of small bowel obstruction. I think we're back to my country, it's going to be the big change of my emergency department to use that. So let's review a little bit about the size of the small bowel obstruction that you can see from the POCUS, because it's very easy to use. So you have to scan your patient belly like this, like mow the lawn, right? From the right upper quadrant to the left lower quadrant. Yes, you can use a bunch of gel and you have to perform a sequential compression with a transverse view. And you have to find for some of any size of this, like dilatation of the small bowels more than 25 millimeter, or any peristaltic movement or to and fro movement inside the bowel, and it may be cause some thickness of the bowel if it lasts for many hours, like more than 2 millimeter of the thickness of the small bowel, and sometimes it's late finding of the small bowel obstruction. We can see some interperitoneal fluid accumulate on between the bowel, and we can call that tanga side. It's just like a triangular shape of the fluid between the bowels. Okay. As I know from the textbook, we call this procedure called this scanning like a mow the lawn, right? But it's from American style. So for the Canadian, we can use plow the snow. Okay. So for this question, so do you think your patient had dilated large bowel loop? No, it's not the large bowel, right? It's small bowel, and this is the jejunum. So you're gonna say no for this quiz. Okay, I will go to the last case. She is the lady, 20 years old female, present with the left-sided paretic chest pain for 3 weeks ago. Her vital signs stable, except a little bit tachycardia, and she has no fever. Okay, could you please help me to interpret this view?
Don't feel shy to target a question to people.
Okay.
Yes, not
Any-
I'm not sure if that's an epicardial fat pad or if that's precardial effusion, to be honest.
Okay, thank you so much. It's very good. Okay, so it's good that you say that you're not sure. Sometimes I'm not sure too. So okay, let's start with the basic thing. Like this is the liver, right? It is the liver is a acoustic window for the subxiphoid view, and this is the inferior pericardium, and this is the very important interface that we have to take pay attention on, see some fluid, and you can see the black line here. Okay, and some this black line, you can see it constantly while you fanning from the anterior to the posterior of the patient heart. So it could be pericardial effusion, right? But sometimes you're not sure. So when you're not sure, so you can put your probe to see another view of the heart, and this is one of standard heart view, and this is palatal long axis. Could you please tell me again, is there any pericardial effusion from this view?
Yes, We do
Yes,
see
I
it
think
here.
there's
Yes,
a
please.
silver of it. It's not major, but there's a tiny bit of it.
Okay. Very tiny, right? Thank you so much. But now you can see it's very clearly that there's some tiny fluid between the heart and descending aorta, right? It's very important anatomical landmark for a small pericardial effusion. For the heart, okay, it is the left atrium. Is it the left ventricle? It is the valve of the aortic valve, mitral valve. You can see it's very good in opening or excursion of the mitral valve. It can touch the interventricular septum. So now you can confirm that it's very good fraction shortening of the LV, or it's very good systolic function of the LV, because the EPSS, or the descent between the anterior mitral plate and interventricular system, is really less than 7 millimeter. So it's confirmed it's really good contraction of the LV. Okay, and for the chamber, one third, can you remember? So for the LV, the root and LA is very equal. So it's normal for the size. So let's take a look on the function of the heart in overall. Is the LV like the donut, right? Is the RV like croissant? So this is normal LV contraction and no regional wall motion abnormality. I move to the apical four chamber. So is there anyone see any abnormality on the heart, this heart?
I think there's something pressing in the right ventricular wall.
Right ventricle, right? Okay. This
There's
is the like our left. Sorry. Please tell me. This is the left side, right? This is the right side. The left left ventricle is look like the U shape. The right ventricle is look like the V shape, right? And you can differentiate the left and right with using the valve. The mitral valve located in the basal part. This is the basal part. This is the apical part. So the mitral valve located in more basal part compared with the tricuspid valve. So this is the left and right. Okay, I recall you sometimes you're confusing with the left and the right. Okay, I'm sorry, doctor. Sorry, I cannot remember your name, but I saw I heard that you mentioned about the right ventricle. Yes, I saw something like you. There's something so weird. It looked like hyperechogenic lesion on the right atrium. What are you thinking about? She's a lady, 20 years old female, present with the chest pain, pleuritic chest pain on the left side. What it could be?
She has pericardial effusion.
What it could be?
Does that represent RV strain?
Very, very tiny, right? Sliver.
I would be concerned for a cloth.
Oh, okay. Yes, thank you so much. I will say that I on that day I thought like, oh, it could be like a thrombus, right? Because the patient is young lady present with pleuritic chest pain, and it's gonna be like clot inside the heart and cause her pleuritic chest pain from PE, right? Okay, from this, again, for the basic thing, you can see the very good contraction of the LV, right? It's very good systolic function. For the RV, you can see its movement longitudinally. It's very well movement up and down, up and down. And from this distance, up and down, this is more than 15 millimeter. Okay, it confirmed that the patient has a very good function of the RV. So this patient has very good RV systolic function. Okay, sometimes you can use M mode to see how good of the RV function. And we call TAPSE. TAPSE means the RV contraction in the longitudinal plane. You can apply the aim more part of your caliper in the lateral side of the annulus of the diastolic valve. And this is the distance of the movement, up and down movement. And the distance is around 2.1 centimeter, which is greater than 1.7 centimeter. So it means it's very good function of the RV systolic function. And again, I use the Doppler. One of a really OCD patient when I saw something like that. So I used the color Doppler to see any leakage flow on the tricuspid valve, and there's no regurgitation of the tricuspid valve. For this is the IVC, and you can see the diameter and the collapsibility is within the normal limit. Because the patient presents with the chest pain, so I take a look onto her bilateral pleural cavity. For the right side is normal, but for the left side, you can see there's some black area in the posterior or far field to the spleen, right? And how to differentiate the fluid from the artifact from the liver or the spleen. So you can see these lines connect between it is the spine, and it's connect to the line lower than diaphragm. So it's continue at spine side here. So it's confirmed there's some small or sliver of the tiny small amount of the pericardial effusion. Oh, sorry, pleural effusion on the left side. Okay, I sure that everyone know that it's very POCUS is very good. One of the best to diagnose small fluid, even if only less than 50 millimeter. So because there's something abnormal on the left side of the chest, that the patient had the pain on that side. So I use the probe, linear probe, to see on that area the patient has pain. What are you seeing? Is there anyone help me to interpret that?
There are B-lines.
Yes. And
Multiple, scattered.
multiple, very good. What are you thinking about?
Pulmonary edema, regardless of the cause.
Okay, thank you so much. Everyone will concerned about pulmonary edema, and every time you say B-line, okay, I know, and one of the one of the person who concerned about that. Okay, this is the subcutaneous layer, right? It's the chest wall of the patient. Okay, and we have to pay attention on the interface between the lung and the chest wall, and this is pleural line. And you can see it's like here. So from the pleural line, it should be very smooth line, right? But for this patient, it's irregular pleural line with some thickening, and you can see some irregular, like a lumpy, bumpy, right? This B line is a bright line here, multiple B lines. You have to look carefully at the pleural line, because sometimes you can name that it's pulmonary edema. If you saw the pulmonary edema, it should be like in anterior and lateral and posterior and everywhere and bilaterally, right? And for the pleural characteristic, it should be regular and smooth, okay, like this. For this patient, it's irregular. So you have to think about some pleural disease like a pneumonia, pulmonary infarction, which is from PE, right? So as a blue protocol, as you know, this protocol for the rest of the lung of this patient has the A profile. So because of there's lung sliding side and there's some C profiles, maybe pneumonia. And you can see from this protocol, there's no PE in this protocol, right? And it's only PE. It's if you saw A profile, you have to take a look on the leg, and if you see any DVT, it should be thinking of PE. So for this lady, because she's very young, present with pruritic chest pain, some tachycardia, and we saw something like maybe pneumonia or maybe submassive PE. So I searched for DVT for this patient. And this is the picture that I used the probe to see that the area of the both femoral area, and it's the vein, it's the artery, and I can compress it totally. Yes, I can compress it all along the femoral vein. So there's no DVT on the femoral area. And for the popliteal area, this is the vein, this artery, I can compress it totally, compression. So there's no DVT on the femoral or the popliteal veins area. So because I'm not sure about the fighting of the heart, that I saw something like the clot inside the RA chamber, and which is fighting, this may be some irregular pleural, which maybe which could be submassive PE. So I send the patient to I consult cardiologist, and she's was certainly received the heparin. She was given the heparin for prevent more clot. This is the patient history. She's known for SLE, and she has history of ocular thrombotic event, and she used to on anticoagulant for 1 week, and on exam is within normal, and her investigations are normal except anemia and elevated LDH, CRP, and significant D-dimer elevation. And yes, we send the patient to confirm with a CT scan on her chest, and this is the finding. This is an occlusive thrombus at the left lower lung, and this is some opacity on the peripheral left lower lung related to hemorrhage or small lung infarction. And you can see comparing with the plain film X-ray, it's very hard to confirm the X-ray because it's not the good to detect the small PE. And yet this is the case that we have the non-massive PE. Actually, for the non-massive PE, the cardiologist could manage as outpatient unless the finding of the heart POCUS of this case, which suspicious of the right atrial thrombosis, and it may need emergency special treatment like thrombectomy or thrombolysis, right? So in this case, we consult cardiologists, and they stop discharge of this patient, and the patient has been decided to admit to investigate more. And one day at ward, the patient received the TANS thoracic echo. I mean, formal the formal echo from cardiologist, and this is the finding from the cardiologist report that there are no RA thrombus or mass. There's a linear echo density within the RA on multiple views, and it is consistent with prominent Kyrie network. Sorry, I missed Kyrie network, and there's some mild pericardial effusion. So what is the Kyrie network? To be honest, I never heard this medical term before. That's why I need to give you some review. Okay, for the Kyrie network, it's not the new finding. It's an anatomical variance, which found in 1, 2 or 3% of normal human heart. It is a mobile net-like structure and occasionally seen in the right atrium near opening the inferior vena cava and coronary sinus, and it is usually of no clinical significance. However, it's very confusing with the right atrial pathology, right? For example, in this case, and this is some clip that I grabbed from the internet. You can see it's very similar to our patient. It's a Kali network. And there was some reported case from the emergency department that has been reported detect from the bedside, which make the patient to be concerned about the emergency condition like the thrombus. Some of cases that's concerning for the RA thrombus need to be evaluated by cardiologist again. He's able to differentiate Kali network from the pathology of the right atrium. From this is the TEE, we can confirm that it's not the clot. So I want to show you some case that I grabbed from my country, my emergency department in Thailand. You can see this is our case today, and this is my case in the past. You can see the dilatation of the RV and RA is really large, and there's some clot inside. It's the real PE case. So in that case, it is upside for a view. You can see the dilatation of the RV, and this confirmed with the CT scan. There's bilateral and massive PE on the main pulmonary artery. This patient received thrombolytics immediately bedside in ER. Although it is usually considered a normal anatomical variance, and I think it's very it's good for us to have a careful differential diagnosis with the RA thrombus. So this is a summary how to differentiate the RA thrombus from Kali network. For the RA thrombus, it should be more likely to present with a highly clinical suspicious of VTE, and sometimes has a very unstable vital signs. And for the characteristic of the RA thrombus, is should be in a linear, tubular, and free movement. It may extend to the RV, or we call in transit clot, and we should search for the signs of pulmonary hypertension, sorry, not portal. And we can see the dilatation of the right side of the heart and TR. And sometimes we have to confirm with confirmation test like a TE, formal TTE, or 3D echo or cardiac MRI. And there are some signs of pulmonary hypertension. Sorry, I cannot explain to all of you today, but this may be some signs of pulmonary hypertension from POCUS that I can that we can use to differentiate the real PE from the normal pathology, normal Kali network. Okay, if I have time, I will present you in the next time. Okay, for this case, there's PE and DVT on above the femoral area, and once we know that it's not a RA thrombus, we stop heparin for her, and she was discharged home with oral anticoagulant. Although there is no complication to my patient, but she needs to stay longer in the hospital to prove about the RA pathology. For me, I thought that if I know about the Kali network before I saw this patient, I should discuss with these things with cardiologists, and it would be better to discuss about this before having the patient to take a risk of anticoagulant with our unknown ultrasound finding. Okay, and yes, for this quiz, you can see tiny fluid, right? So it's a yes for this quiz. And yes, it's a very small perfusion. Oh. And for this, it's only cardiac network. So it's normal heart. And for the last one, it's not pulmonary edema. It's PE, not massive PE. Okay, so this is the answer of our quiz. I hope you enjoy my presentation today. And okay, no worry if you are one of the person who answer a lot of C's. Not sure, sorry, choice. I would say you are the best one who not lie to yourself. And I hope some of my guests today may encourage you to learn more and practice more about the POCUS. For me, POCUS is like my buddy, my friend, and it's helped me a lot to visualize my patient from the bedside. Thank you for having me today. And if you have any question, you can email me, or I'm happy for any comment. Thank you so much.
Thank you so much for this great presentation. Lots of great case. Really, thank you for being here. And once again, it was last notice. There was a change of presenter. So I want to underline this and really thank you for being here today.
Thank you.
Do you guys have any question before we go to another presenter?
Oh, sorry, I have to stop, right? Stop here. Okay.
It doesn't look like there's any question from the chat. So if people do, just don't hesitate and put the question in the chat. Thank you again.
Yes, please. Thank you so much. I would like to learn from you all too. Thank you so much.
Next up is a special guest from Université Laval, Vincent Gauvin, who's now a TTL fellow, who's going to be presenting about ED thoracotomy and TCA. Vincent, are you up?
I am. I'm just going to share my screen.
Great, thanks.
Okay, great. Everybody seeing that?
All good.
Excellent. So, hi everyone. My name is Vincent. I'm a specialist in emergency medicine. I graduated from Laval University. I'm currently a TTL fellow at the UBC in Vancouver, and I'm doing a 2-month elective at MGH. I would like to thank Dr. Nemeth for this opportunity. And then Joe, if you can be my mediator for this and look at the chat and keep me up to date on the questions or anything. So the objective of the talks: understand the prognosis of traumatic cardiac arrest based on various clinical elements, recognize and treat the 4 reversible causes of traumatic cardiac arrest, discuss the indication to perform thoracotomy, and explain how to perform the procedure. Let's start with this paper. This is the positions paper from Ascot from 2013 that caused lots of critics. They state that it's appropriate to withhold resuscitative effort for certain trauma patient for whom death is a predictable outcome. This was taken like as a concept of it was possibly futile to resuscitate trauma patient. Let's just be honest, and important to appreciate that the majority of the studies stated in this paper are more than 15 years ago, and the classic paper from Mattock published in 1982 showing that patient with chest trauma that arrested had a survival rate of 0% is more than 30 years ago, and there's a lot of more recent data on this. In 2016, Evans and colleague published a retrospective study in the US and in Canada, 2,300 patients, 19% of them had a cardiac arrest before EMS arrived, 66% of the patients bore blunt injury. They showed a survival rate of 6.3%. Then in 2017 in the UK, another retrospective study from data, 705 patients, cardiac arrest on field or in the ED, 85% blunt, which looks like the population in Quebec, showed 7.5% survival. It's important to understand that like these studies have a lot of bias. Some of the traumatic cardiac arrests that are happen on field are not incorporated in the data. So there's clearly probably a small increase in the survival percentage for sure. But first key element, I think it's important to be realistic and not pessimistic. So the survival rate from a traumatic cardiac arrest is not 0%. It's somewhere between 5, 6, 7%. It's always hard to determine it. But with some key clinical elements, the survival rate from some of these patients is close to 20%. So it's super important to make sure that we know where our patients stand on this slide. The literature is very heterogeneous, so it's important to take your own mind and analyze the patient very well. So I think one of the most important part is to be able to identify the predictable outcome, to know which patient can have a good outcome and which patient should have a more aggressive resuscitation that could potentially save his life. So here are a few elements that are very important and are good possible elements to look at to know if the outcome of this patient can be better. So the presence of vital signs at any time, patient suffering from a penetrating injury, presence of electrical activity, a short time since the arrest. So when we say short, everything in less than 10 minutes, it's considered short, but the shorter, the better. The presence of cardiac contractility on POCUS, and the presence of the other signs of life that are spontaneous movement, respiratory effort, or pupillary reactivity. In the absence of all these factors, so all of them, if none of them are present, we know that the survival rate is less than 1%. Recently, in 2018, Bellal and colleague published a retrospective registry study from trauma. It's done over 5 years. So from 2010 to 2014, they were able to find 2,229 patients that had thoracotomies. What they identify is from the year 2010 to the year 2014, there was a decrease in the number of thoracotomies that were done, but also an increase in survival. It went from 8% to 11.3%, which make them think that they're using more, respecting more the indication and not doing ER thoracotomies on patients that should not have them, and also that the post-thoracotomy care got better. The other very interesting part is this graph. As you can see here, having an ER thoracotomies over 70 years old, there's zero survival in the old group, either blunt or penetrating. And in the over 60-year-old, there's no survival for blunt injury. So their conclusion is that it could be futile to do an ER thoracotomy in any patient over 70 years old or in blunt patient over 60-year-old. I don't like to use age as a criteria because every once in a while you're climbing Camania Wood and you get passed by 65-year-old, very, very fit individual. So age is a factor, but it needs to be analyzed based on comorbidities and everything, because we all know a 65-year-old who's fitter than a 30-year-old. So it's important to consider the global patient over this. Then Panosian and colleague in 2020, another big trauma registry study from 2010 to 2016, 2012 patients with ED thoracotomies in the first 60 minutes. It's the first study that really used the codes for thoracotomies done in the ER. So I think it's the most interesting one because it's the part that concerns all of us. They were able to identify factors associated with death using some multivariable logistic regression, but some things is clear. So having a blunt injury, there's an odds ratio of 4.03 of dying. No signs of life, 3.64. Age older than 60 is still present. A pulse below 60 in the ED and in the pre-hospital setting is big predictive factor for death. And then an ISS score over 16. What about cardiac contractility? Is it good? Should we use it? The answer is yes. It's really good. So this study from California in 2012, published in the Journal of Trauma, showed that in 162 pulseless patients, having the absence of cardiac motion, either if you have electrical activity or not, had a negative predictive value of 99%, which is a good thing to use to decide, should I crack the chest of this patient or should I just stop here because there's no way he's going to survive. In 2015, another interesting study. So in LA County monocentric study, prospective data in 2015. So in the 187 patients that had a ER thoracotomy or clamshell, they looked at their initial POCUS. So they look if the initial POCUS was negative, did the patient was positive, did the patient survive? If it was negative, did the patient survive? So what they saw is that no patient had no effusion on the POCUS and no cardiac motion on the POCUS survived. So for them, it's clear that if you do your initial cardiac POCUS and there's no pericardial effusion, no cardiac motion, probably the patient should not have ED thoracotomy. What's this? Sorry for the red mark on my screen, I don't understand. So key elements number 2 to remember. So establish a prognosis early in your resuscitation. So POCUS is your friend, look for electrical activity, look for the downtime of your patient. Is there any signs of life? What's the mechanism and what's the age and the comorbidities of the patient? Knowing that over 70, the chances are very low that this patient will survive from a ED thoracotomy and over 60 in a blunt mechanism. So before we get fancy and think about opening the chest, we always have to remember the basics. This is in every emerge doc wheelhouse and should be addressed first. I'm talking here about addressing the reversible cause. In trauma, I see the reversing the reversible cause like as important as good chest compression, early epi, early defib in a medical arrest. But in trauma, this is really where we should focus on. So always think HOT. This is the mnemonic we need to remember for hemorrhage, oxygenation, tension pneumothorax, and tamponade. Those are the 4 reversible causes that we need to address during our resuscitation. And for treatment, so same mnemonic, HOT. So hemorrhage control. First thing, is the patient pouring blood from somewhere I can control? Can I apply a tourniquet? Can I use direct pressure? Should I put a binder on? Then oxygenation, does my patient have a definitive airway or is my LMA placed by pre-hospital working well? Then finger thoracostomies, okay, on both sides. No need to look for lung sliding or do a chest x-ray, right? The patient is either dead or actively dying. So we should just act on it and make sure that we rule out some tension pneumothorax. Then we need to fill up the tank, right? Hemorrhage is the #1 cause of shock or death in trauma. So we need to give some blood or transfuse the patient. If you don't have access to blood, we need just to fill him with saline or whatever, which is not the best. And then we should look for tamponade using our probe. And at the same time, we look for cardiac motion to state and make a prognosis on the fact that should I do an ED thoracotomy on this patient. So key element number 3, make sure we prioritize the reversible causes in traumatic cardiac arrest. It's important to prep your team, right? Explain why there's going to be a moment you should stop CPR to make sure all your it's safer to address the cause and nobody's going to get hurt and nothing is going to be in the way. So make sure you prep the team, tell them why you do it, and make sure that everybody understands his role. Because I think the treatment for the reversible cause when you receive a traumatic cardiac arrest, it should be addressed probably in the first 2 to 4 minutes. I think the patient should, depending on how many people you have, but patient should be tubed, bilateral finger thoracostomies, IVs in with blood pouring in, and then somebody doing a very good cardiac POCUS. So I think all of these can be done pretty quickly, and you can assess for where's my patient on this prognosis line, and should I perform more aggressive resuscitation by opening the chest of this patient. So
Vincent?
Oui.
There's a question in the chat from Dr.
Yeah.
Doral saying, how in that context do you define contractility? Is just any signs of it? And how much time should be spent doing this regarding the analysis of the contractility?
I missed the first part. Can you repeat?
Yeah, no problem. Dr. Doral is asking, how do you define contractility of the heart in that context? Any sign at all? And how much time should be spent doing this?
Yeah, it's a tricky question, right? We know that looking for cardiac standstill, you look at data, there's not good inter-observer data on this. Like we know that people don't agree that it's cardiac standstill when you look at the data. So I think you look for motion, right? If you see like motion compatible with life, I would define it like this. It's important also to be able to say this is non-concluent, right? There's going to be lots of things happening at the same time as your echo. Probably there's going to be subcutaneous emphysema because it's a trauma. So there's kind of a good chance that you're not going to be able to see something, and it's okay to call it a non-concluent. And I think it's our duty to do so. So I would not spend like lots of minutes doing it, but I think like make sure you do your best view that you're able to do, and then continue on it. Then ED thoracotomy, so two big societies. So we have the East one and the Western one with the standpoint on this. So if we discuss the East part, so the only strong recommendation, and I think all the residents should look on this because maybe you're gonna have a question on this on your upcoming board. So the only strong recommendation is patient with cardiac arrest that has a penetrating chest injury with signs of life should have an ED thoracotomy. When you look at their meta-analysis from 2015, these patients have a 21% chance of survival. Then conditional recommendation, cardiac arrest, penetrating chest again without signs of life. Chance of survival, 8.3%. Then penetrating anywhere else with a cardiac arrest, with or without signs of life, it is a conditional recommendation. When you look at with sign of life, 15.6% survival. Without, it drops very low to 3%. Then conditional for blunt trauma with signs of life, survival rate around 4.5 to 5%. And then I think this is the one you need to put in your head. It's super important. So cardiac arrest, blunt trauma, no signs of life, no ED thoracotomies, okay? This patient should be, we reverse the causes, the 4 reversible causes. We look for signs of life. If there's none, we have to stop and pronounce the patient. Sometimes it can be hard because our blunt trauma patient can be healthy, young patient. But if you have no signs of life on a blunt trauma, the survival rate is less than 0.5%, and none of these patients in the studies are neurologically intact and going back home. So it's important as a clinician to pull the plug and decide to stop the resuscitation on these patients. When we look at the Western Trauma Association, so patient undergoing CPR with no signs of life, they say blunt less than 10 minutes or penetrating less than 15. We should do ED thoracotomies. If it's in the neck or in the extremities, they put the time down to 5 minutes. I think like this is like for the penetrating injury, I still understand. For the blunt, the data without signs of life are very, very, very poor. I think we should be like you need to make sure you look for everything before you decide to like open a blunt trauma without signs of life. But based on these guidelines, you could do it if it's less than 10 minutes, and opinion varies on if you should apply it with no signs of life for a blunt trauma. Okay, let's discuss rivalry. So anybody knows what I'm talking about with this rivalry between the Canadian and the Toronto Maple Leafs?
I'm assuming yes.
Excellent. So I'm talking about ED clamshell team against ED thoracotomy team. So it's there's people that claim that we should do a clamshell right away, and others saying that we should do thoracotomies and then convert it to a clamshell if needed, based on speed and exposition to the structures. So here is a bit of literature on it. So should we do a left anterolateral or a clamshell? So for speed, we have a study from Flaris in 2015. So 16 surgical residents, 8 of them did the one technique in the cadaver, and 8 of them did the other technique on the cadaver. There was no crossover between residents, right? They just did one technique, and then they looked for the time to exposure. So it was faster with the clamshell, and they were able to control the cardiac rhythm a bit faster in the clamshell too. Then Newberry colleague, 2020, 15 ED physician on cadavers performed the procedure, 1 ED thoracotomies and 1 clamshell each of them, and they were comparing their performance. So it was exactly the same in both groups, but the patient preferred the clamshell. Let's be honest, those 2 studies have no external validity, right? First, the first one is surgical resident, no crossover between a group, and something like this makes no sense. And then the one with the ED physician, first, there's no difference. And the other thing, it's on a cadaver, it's really not the same thing. Then Dubose and colleague, 2020, they did a prospective study on the aorta registry. 1,218 thoracotomies, showing a survival rate of 6%, which is okay from 2014 to 2020. The thing they noticed is that doing a clamshell right away was not associated with more injuries, not associated with more transfusion, no more days in the ICU, and no change in survival and no change in hospital days. So based on this literature, I think it's based on my thinking is keep it simple, okay? Do a technique that you know, that you have rehearsed and you have practice. And also the other thing I want you to remember is consider, I don't want you to finish this talk saying, oh, I need to crack every chest. I want us to consider doing it for the right patient and in the right environment and setting where you have backup and access to definitive care. So this talk should not be, oh, thoracotomies are cool. No, it's thoracotomies should be thought of and done on the right patient at the right time. Okay, so let's talk about the technique. So this is a picture from Maddox 7. So the incision should be done at the 4-5 intercostal space. And I would add that your incision should start at the opposing side of the sternum to be able to convert to a clamshell if needed. So first step, you splash the chest with whatever iodine, chlorhexidine. Then you do your incision. It's important. You need to put pressure on this knife, right? You want to go pretty deep. So you only have to do 1 knife shot. So probably until the rib. Then with your scissor, you cut the intercostal space. Then with your hand, you open a bit the space. You put in your rib spreader and you extend the chest. So this is from Robertson Edge. So that's how you should use your scissors to cut the muscle just above the ribs so you don't injure your intercostal artery. That's how you should position your rib spreader, right? You want it to go towards the bed. So if you have to convert to a clamshell, it's not gonna be in the way. So here is a video of one of the thoracotomies I had the chance to work on. So you see here, so the incision is starting on the opposite side of the sternum and then prolonging the position of your rib spreader. And you can see that you can wank the crank a lot and open up. So this is after the patient sustained ROSC. So here you see the lung, here you see the heart. The pericardiotomy is already done here, so there's no more pericardium here. So once you enter the chest, usually you can use your right hand, the dorsum part of your hand, to push on the lung to bring him up. And then you're gonna have a visualization of the heart. Once you see it, you'll be able to identify the phrenic nerve and then cut open the pericardium parallel to the phrenic nerve. Here's another picture of how to open the pericardium. One thing I have to say is the first time you'll do this, it can be hard to distinguish the diaphragm from the heart when the patient is in cardiac arrest. So never cut something that you're not sure, okay? Take your time, move the lung up. You can also pinch the hilum if you need to help you move the lung up, and then visualize the structure. Take your time. So the things you need to do, you can do. So open the pericardium, control hemorrhage with a finger, staple, sutures, a Foley maybe, but I think this is long shot. I think for an emergency, the best thing is put the finger on the bleed and wait for someone to come and help you. Repair cardiac lesion, a lung lesion, clamp the aorta. So when you look at textbook and think they're talking about that clamp, I think for us, the best thing is to use your hand and just press on the aorta and occlude it on the spine like this and just stop moving your hand. Usually when you do it, you're gonna have a response. You're gonna start feeling the aorta pounding in your hand. Just make sure you compress it very hard. Then you can do open cardiac massage and give epi right in the heart. Key element number 5, know your procedure and practice. During my training in emerge, I had the chance to do a 2nd degree in medical education, and one of the very powerful tool is mental preparation, okay? For high acuity, low opportunity procedures like this, we should practice them in our head. Personally, I do it once a month for procedure like CRIC, ED thoracotomies, perimortem C-section. I just take 10 minutes and just practice. It's like prepping for the oral part of your Royal College, but for real life. So it's quick, it's easy, and we know with data from literature that it's working. People, when they get through the procedure after, they're calmer and they're more confident. So we should practice this a lot. What are the outcomes of ED thoracotomies? So here is the data from the 2015 systematic review from the EASE guideline. So what they show is, first of all, when you have signs of life, your chance of survivals are way higher. So penetrating chest with signs of life, 21%. Other penetrating injuries, signs of life, 15.6, and going down like this. I think I like using neurologically intact as a better outcome than survival. It's about 2/3 of the patient that finish neurologically intact, which makes it's okay, but you still need to look at it. Like a blunt patient with signs of life, it's still only 2% are neurologically intact, which is very, very, very low. And more recent data, Panicin and colleagues, same study from the trauma registry from the States. So they have a very high survival rate, around 20%. It's a lot more than the other studies. Probably what they say, it's because their decision to perform a thoracotomy is not always based on the guidelines from EASE. So they say that there's less thoracotomies done in the wrong patient than the post-thoracotomy care that are better. The other thing is, when you look at the population from the state, look at how many penetrating injuries they have, which trend their survival up. So for blunt trauma, they had 7.5% survival, and for penetrating injury, 26.1. In their whole group, over 2,000 patients, 91% of these patients arrive in the emergency department with vital signs, okay? So only 9% of them were in arrest before their arrival. So this is a critical data and could explain why these patients have a higher survival rate than in previous study. When we split the penetrating injury, we see that having a stab wound is a way higher chance of survival than a gunshot, because usually it goes to a trajectory and then you can just put your finger on the injury and then the patient can go to the OR. Then from this patient that survive, how many of them are able to go back home? So two-thirds of them are able to go back home. Unfortunately, with their data, we're not like, they didn't know Glasgow outcome scale like we would have wanted to know exactly, is the patient fully independent, is the living alone, or it's partially, it's hard to tell. We don't know. That's one of them. The missing, I think they should have done a Glasgow outcome scale on this patient and know where they are neurologically, but around 66% are going back. So to conclude, here are the key elements. So establish a prognosis early in your resuscitation. No effusion, no cardiac motion, you have to stop. We also have to be able to say that this is non-concluent. I'm not going to use it to prognosis this patient. I'm not able to see. So that's our duty to say, I'm not able to see. That's fine. I'm going to use all the other elements to take a decision. Prioritize the reversible causes. Okay, think hot. So hemorrhage, O2, tension pneumo, tamponade. Know your ED thoracotomy's indication and apply them in the right patient and the right environment. Know and practice your procedure. This is a skill that we're able to do. We just need to be ready once the good patient in the good environment shows up. So thanks everyone. I'll be happy to have questions, and also I would love to that people share their experience. We have a few TTL in the audience, so let's share our experience and have a good discussion on this subject.
Merci Vincent, great presentation. Thanks for being here this morning. Actually, there's a question in the chat and I have the same. What are your thoughts about the surgical facility availabilities that you have? Let's say that you're 20 minutes from a trauma center where they do have the surgical capacities and you don't. Would you still crack the chest open? Do you have some time frame in between?
Yeah, so it's a good question, and I think it's a personal answer. So like, let's put it to the extreme. You work up north, there's no surgical capacity whatsoever in a timeline that's reasonable. There's no way I would proceed with this. Okay, if I work in a center that's 20 minutes away from a trauma surgeon, and I have a penetrating chest trauma from a stab wound that I think I can, like I see a tamponade and I think I can put the finger on it, like I would crack the chest because I've done a few, and I think I can do it and like compensate and like staple or whatever. But like, I think when you're in an environment, there's no surgeon, you will never be blamed if you don't, because there's no one to help you, right? This is like an IL thing, and I think it's totally okay in the non-right environment and setting not to proceed with this procedure.
You obviously have to take into consideration the time that you would have once that chest is open, the time to transfer you would have, and all of that, right?
Yeah, exactly. You have to take into consideration the resources for sure, right? Doing this alone is something completely crazy. Like even alone at night in a center where you have the capacities, but you have 60 ED patients, you still have to take this into consideration. Like this is gonna take you 1-2 hours, and all of the other patients will not be taken care of. So like, it's a complex decision. All of these factors needs to be taken in, but like if it's a penetrating chest with signs of life, like you look at the data, this patient has 1 out of 5 chance to be alive. It's big, right? So it's like, I see this category as being different of the others, but yeah.
Joe or anybody else? Do you have comments on that?
So along the same lines, I have a question. What about sort of doing something in between, putting a catheter into the pericardium as a temporizing measure and transferring the patient like that? That's another classic question we get from the rural and the community physicians. What are your thoughts on that?
So there's a meta-analysis from 2011 on this. So pericardiocentesis and trauma. The problem is like, it's gonna be clotted and like, it doesn't seem to work. That's the problem. When you look at specifically at data, I don't have any experience in it. Like I haven't never done it. So like, I don't know. And I would like to have your opinion on it because you're way more experienced than I am.
Yeah, so for questions like this, I always defer to Dr. Duchamplain. He's probably the expert in this. So, Francois, what are your thoughts on the pericardiocentesis in trauma? If he's on. Yes.
I thought he was
yeah,
on.
yeah, I completely agree with you, Vincent. First of all, you might do more damage, although how much more damage can you have if you have a laceration of the right ventricle? But yeah, it's you're not solving the problem, right? If you have a clot, good luck. If you don't have a clot, you're just draining off blood, and eventually the patient will succumb. So yeah, I agree with you that I would not fuss with that. One thing you had mentioned that caught my my ear was when Anne-Sophie asked you about performing this in a community setting, and you said, well, I've done a few, so I feel comfortable. Well, I will tell you that a very, very brief anecdote. There was a physician about 20 years ago at the General, just started TTLing. We didn't know him from Adam. And there was a 16-year-old that came with a stab wound to the box, and he opened and he saved his life. The patient walked out a week later. And talking to him after, he said that he had only performed one prior to that. And since then, he's performed like 20 with pretty good success rate. So my point is the following. Mental preparation, and you don't need to be an expert. Well, who's an expert? Like, who's done 100 of them? Very few of us, right? It could save a life. So like Vincent says, mental preparation is incredibly important. And you're prepared mentally, you do it. If there are indications, you do it. Don't expect to have like 40 of these underneath your belt to say, okay, now I feel like an expert.
Yeah, I think it's impossible to be experts in procedures like this, where like it's high equity, low opportunity. Like it's the same thing for CRIPE, for perimortem C-section. But like there's one thing we can do, it's be prepared.
Great. Great talk, great discussion. Any last minute burning question?
So can we have Kavi talk about doing this in a very remote setting, because he's practicing far. So what's his thought on this? So would he proceed or?
Hi, can you hear me?
Yeah.
Yeah, this question keeps me up at night because I had a case a couple of years ago. It was a young guy. Where I was working at the time is about 120 kilometers from a small hospital with a surgeon, and I got called in to help for an agitated patient. And I was like, oh, it's kind of unusual to call a second doctor in for that. And when I arrived, they were doing CPR. So I said, what's going on? And they said maybe stabbed. So right away, I told them, I said, stick on a probe. If there's tamponade or retention, we need to needle him. There was tamponade. And so we managed to, within a couple of minutes, using the ultrasound, I was in the pericardial space, really, like it was for sure in the right spot, and just could not get any blood out. And I even stuck a pigtail in there under ultrasound guidance at some point just to try and get something out. And so the only option for this guy was to open the chest. A lot of it, there's no right or wrong answers. Half of my colleagues say, oh, you should have done it. Half of my colleagues say it would have been the most insane thing to do it for many reasons. It's something that would have been traumatic for the community. A lot of it comes down to distance. If you're a plane away or multiple hours away, I don't think there's much point. If you're in a village that's 30, 40, 50, maybe 80 kilometers, maybe there is a point. You have to kind of understand the devil's in the details. If you've got a cardiac laceration that you could potentially plug with a finger, I don't think I would be futzing around with a Foley. I would stick a finger in it. And the only other thing you're really going to be able to do is maybe put your hand on the aorta. If it's a massive pulmonary laceration or a vessel laceration, the patient's going to die. So it's a very specific situation where you have to be within a reasonable distance. And I don't have a number for what that is. And then the other issue is, do you have the equipment? Like we did not have rib spreaders or anything else at that point. So you're going to have a situation where you do it, you don't have a surgeon and you don't have adequate exposure. So pretty sure the patient's going to die. There's no right or wrong answer. If I had already done several, then it eliminates that friction and everything happens faster. So there's no right. It's hard to. There's so many factors that go into the decision. It's hard to easily answer it. But I think the biggest factor is going to be distance to semi-definitive care, and how you're going to get there, and knowing that the only things you can really treat are going to be cardiac laceration. If pericardiocentesis would be useful if the blood wasn't always clotted, and that it could buy you some time. And if you can pericardiocentesis a couple of times, yeah, it gives you time to get somewhere. But the problem, and I asked many people after, and everyone's experience who'd actually done it, without exception, was that the blood was clotted. So I'm not sure of the utility of it.
Thank you, Dr. Singh.
Great.
I think you touched on something very important, and it's equipment. Okay, one of the things I would recommend also is like when you start working in a new emergency department, either as a new grad or doing locum, know where the ED thoracotomy kit is, and like at least once you should open it. Okay, I know it costs money, sterilization and everything, but you should open it just to build the spreader. Okay, like 9 times out of 10 it gets open and a piece of the spreader, the rib spreader, goes on the floor. And there's usually 2 spreader, one for the sternum and one for the rib. So make sure you're able to use them, know which equipment you're using and how to use them. Because like in the emotion, the initiation of the procedure, sometimes you won't have time to prep. So if you know really well your equipment, know where it is, know how to use it, it's gonna help you and keep you calmer also.
Great. Thank you for this really great presentation. Ça suscitait beaucoup de discussion. We're going to take a 10-minute break. We're a bit behind on time, but I think that was worth it for sure. So I suggest we all come back for 9:56, and Humaid will do his grand rounds. And if you guys have more questions in the presentation that does happen, maybe I suggest that you put it in the chat. So 9:56, guys. Merci encore, Vincent. Hi, Ume. Do you want to start sharing your screen so we're ready to start in time?
Sure. Can I share now? Do you see it?
Yeah, you just have to make it in full screen.
Is it good?
Yeah, all good. So welcome back, guys. We're gonna get started. Humaid is gonna do his grand round presentation. So floor is yours.
Hi, everyone. It's me again. I'm the emergency resident, one of the emergency resident R2. Thank you for Dr. Vincent Govena about his topic. And today I'm going to speak about the acute migraine treatment. There is no like adrenaline surge, or there is no knives, no blood. I'm going to talk about the evidence, the level of evidence about behind the medication, the treatment, and what's new in the treatment of migraine. I know it sounds a little bit boring, but always there is something new in each topic in the medicine. So I'll start first with the cases. So I may ask one of my colleagues, residents, about to volunteer to read the case or solve the case, one of the R1s.
I can take it.
Okay, Hamda.
Okay, so we have a 23-year-old female with known history of migraine presenting with unilateral headache, pulsating in nature with nausea and vomiting and photophobia. She reported that this headache is similar to previous attacks, but now she has vision changes also. There's no focal weakness, no fever, no neck stiffness, no history of trauma. She's taking metoprolol 15 milligrams BID regularly to prevent the migraine, but recently she sleeps only 4 hours a day. Since she started to take metoprolol this first time, she experienced a migraine attack, normal neurological exam.
So about the vision change, that's what the patient is like describing. Like, would you be worried about this like change?
So it's this, I mean, scotomas are something that we can see as an aura of migraine, but I'm just wondering if this is a new symptom. I don't know if that makes it more concerning.
So yeah, usually with like with the aura, a migraine with the aura, we can see some scotoma, but sometimes it will be something new with the patient, and sometimes it will be something it's like come again and again with this aura. Yeah, if something new, it might be like, it worried me a little bit, I'm gonna go do some other tests. But if it is something recurrent, I don't like be worried about it. So for the treatment option, that's what you have. So I give me an answer. I won't like say my answer now. After the finish my lecture, we'll go back to the questions. So this is the treatment option you have available. And
okay.
Yeah.
So one thing there's a triad, right? So NSAIDs, metoclopramide, and triptans if needed, especially if it's early enough in the attack. And in case we want to avoid, I mean, I don't know if it's proven by studies, but for recurrence, we can give a dexamethasone dose as well.
Good. So would you consult the neurology for this case? Would you admit the patient?
I'm wondering if about the scotomas, if they resolved. I don't think it's necessary, possibly following up outpatient, and she doesn't need admission. And would I do something else at the moment? I don't. I would advise her. I would advise her against the sleeping hours. She's only been sleeping 4 hours a day. That's most probably the reason for her recurrence, despite the metoprolol doses to prevent the migraine.
Thank you, Hamda, very much. So we'll go to the next case. So it is a 30 years old female with a 36 weeks of pregnancy, known of migraine, presenting with a 2 days history of headache, unilateral pulsating, associated nausea, and vomiting. The patient reported that she has less attack during the pregnancy, but this attack is like the worst attack ever in the pregnancy. No other symptoms, like normal neurological examination. I one of the my colleagues in the R2s to volunteer to this question. There is anybody? Any of R1s, or also if you want to participate?
You have 3 R2 that you can pick on.
So because I don't see the names now, but
I see Antoine, I see Fred, I see Carmine.
so and the R2s, anybody wants to volunteer? So I guess nobody want to be volunteered, so no problem. So we'll proceed with this question. So any of the R3s?
I can pick it.
Good. So what do
And
we
the next
do?
case will be for an R2.
Yeah. So
Okay,
tell
so
me,
yeah.
tell me, and so what do you do with this pregnant lady with a migraine?
I'm sorry, I missed. How far ahead is she in her pregnancy?
36 weeks.
So this is concerning for a future preeclampsia. So before thinking this is a regular migraine, I would do a full workup for preeclampsia. This is where I would change my management in this 30-year-old patient, this female pregnant with a 30 weeks pregnancy, and I would make sure that OB is involved.
Perfect. So as we said, like it is like migraine attacks similar. Let's see, like there is no preeclampsia. What you will do like with the migraine treatment?
So then you've got to be careful with what you give. A lot of things are contraindicated in pregnancy, and so I would have to recheck. I wouldn't give her NSAID. I'm pretty sure, but I would have to recheck that if Maxaran can be given, but I think so. To abort it, I would give fluid, and I don't know about the triptan and what can be used in pregnancy, to be honest.
Good. We'll go back and later about like the answer about this question. And the last question is 25 male known of migraine presenting with the headache. The patient reported that this is number 16 of headache attack in this month, and his headache is resolved only with a medication that he bought when he was abroad. It contains some acetaminophen, aspirin, caffeine, which been advised by his friend that helps with the migraine attack. Also, the patient mentioned that this is his 3rd month in the row having the headache at least 16 times per month. Usually the headache develops upon awakening, normal neurological exam, normal investigation, normal CT head. So anyone want to like volunteer to like have any suggestion how I would manage this patient?
I think at that point, because it's that frequent, I might actually involve neurology.
I can't hear you, Antoine. Can you please raise your voice?
I think I would actually, do you hear me now?
Yeah.
Okay. So I think I would actually get neurology involved, just because in 3 months in a row with more like that many episodes for migraine is a bit suspicious. If there's anything else that could be actually ruled out. The other question that I would have is if you just go back one slide, just to, I'm not sure if I missed, was he known for migraines before those 3 months?
Yeah.
Okay, so basically it's a kid who always had migraines there and there. It's just in the last 3 months, it's really more frequent.
Yeah.
Okay. And they're all similar to his previous?
So it is like similar to the previous like headaches. the migraine, but the thing is, it's been like every day for like 16 day a month, and that's will like repeated like in the 3 months in a row.
Yeah, I would push maybe the investigations a little bit further to see, does he have any risk for like any central venous thrombosis?
No. So we do the CT scan, CT head, we do the thrombosis, it's negative.
Okay, so with the venous phase and okay.
Yeah.
I don't know, it's a good case.
Good. So we're gonna speak about like some about this case also, and we'll go back later on the cases. So and the objective of this talk, it will like speak about the medication available in the AD, contraindication and adverse effect. We'll speak about the treatment in pregnancy, status migrainous, and rebound headache. So why I choose like to speak about the migraine? Yeah, the migraine, it's very like disabling primary headache disorder. It's affecting 1 billion over the world. It's affecting even the socioeconomic and personal impact. It's the third highest cause of disability worldwide. So many people and like having the headaches. All of us knows friends, family have migraine, and how is the migraine affect their lives. So we need to be good with the treatment and the migraine and the emergency. So just quick review about the diagnostic criteria of migraine in case of some patient comes with a headache and no history of migraine, and you rolled out every other things. So you might like start treatment as the migraine till you send him to the specialized doctor. So if it comes with a 4 hours to 72 hours, at least has 2 of these symptoms: unilateral, pulsating, moderate, severe intensity, aggressive, aggravation, or causing avoidance by walking or climbing stairs, having at least one of these associated symptoms: nausea, vomiting, photophobia, and phonophobia. So the mainstay of the treatment in the emergency treatment of acute migraine is the medication. According to the international classification of the headache, there's 2 clinical outcomes: the freedom of the pain for 2 hours and the absence of migraine of associated symptoms for 2 hours. So there is numerous types of the therapies. There is specific pain medication, non-specific pain medication, or non-specific migraine medication, and there's specific migraine medication. Before we proceed with this type, we need to speak about a little bit about the pathophysiology. So the popular vascular theory of migraine, the suggestion that the migraine headache was caused by dilation, blood vessels, while the aura migraine resulting in the vasoconstriction is no longer considered viable. So the understanding of the migraine has been evolving, and there is a lot of like clinical studies and some like imaging studies like migraine. They confirm that the migraine affecting a lot of sites in the brain. And there is like a lot of phases during the migraine attack, starting with the predawn, where there is change in the homeostasis of the hormones in the hypothalamus, affecting the food craving, nausea, like cognitive symptoms. And there's and the second phase is going to the aura phase, where it's something called cortical separate depression, which we'll speak later about it. And then we'll reach to the headache phase, where it's like sensitization of the pain centrally and peripherally, and there is some like changing in the neuropeptides and neurotransmitter in the brain, causing the headache. And after the resolving of the headache, there's some kind of pathophysiology underlining, still working on the brain and causing the post-syndrome symptoms. And there is the last phase is called the interactal, where there's some pathophysiology underlying even of the resolving of the headache and post-drome symptoms. So this is why, like what kind of explain the day after a migraine, still the patients have some feeling, but there is no headache, no symptoms, because still there is some pathophysiology going on in the brain between the migraine attacks. So the cortical spreading depression, it's like in a wave of neural depolarization going through all the brain, like excitation of the brain, following by inhibition of cortical activity in the gray matter. So it will change the synaptic activity, extracellular ion concentration, blood flow, and metabolism occur. And with this lead, this has been hypothesized to activate the trigeminal vascular system, causing the symptoms. So when there is activation of trigeminal symptoms, there is new, I would say, neuropeptide. It was been studied in the past 2 decades and what has been discussed, like approved recently. It's called CGRP, which activated and causing the pain peripherally and centrally. And this is where is the headache phase. And this is where we need to attack the headache in the emergency department. So the neuropeptides contribute to the pain and sensitization pathway. The more like clinical evidence suggests that the CGRP and PCAB, it was increasing in the living during the migraine attack. So and returning to the normal level when the pain is resolved with a triptan treatment. So they did infuse the CGRP and PCAB and induce migraine lack attack. And so they found there is some like similar migraine attack in the migraine patients. So we have another neuropeptide is working in the different sites on the brain, like serotonin, GABA, and dopamine and others peptides. So yeah, the peptides might play a fundamental role in neurogenic inflammation and peripheral central sensitization of the trigeminal system. So this was a brief like pathophysiology explaining. It was just recently changed. It's in a complex thing, and they still like trying to understanding more the migraine to target the treatment of the migraine. So now we'll go like how to approach the migraine patient and what is the treatment. That was published in the Lancet in 2021. There is different strategies. All of them, they are working, but more they like prefer the C strategy where the patient comes with a single, with a migraine, and they're starting with a simple anesthesia. And the same time, if the patient didn't benefit from the simple anesthesia, will escalate the treatment to the like triptan or other medications. So what is the acute medication? So it's include, we said the non-specific and specific migraine. So in non-specific, there is an acetaminophen and NSAIDs, and the specific we have triptans and we have ergotamine. But since 2019, there's 2 medication was approved by FDA. It is an agiptans and ditans, and they are not approved in the Canada yet. So non-specific treatments. So acetaminophen, it's a good drug. Usually will have some like 2 hours pain freedom, and it has like need 12. But usually with the patients coming to the emergency department, they already tried the acetaminophen at the home. This is like the side effect and contraindication. It's basic stuff. We don't need to go through it now. So about NSAIDs, all of them, they are good. Mostly the ibuprofen, and all have the level A of evidence, and also it's considered first line of treatment to the mild to moderate migraine, and the patient it might try it at the home. In the adult side, kind of, we already have the patient will have it. They will already like take the medication like acetaminophen and NSAID before coming to the emergency. In the pediatric side, the parent will be a little bit hesitating to give their kids some like any medication. They might start with a Tylenol and will come to the emergency department. That time, I might be like start with the kids with the NSAIDs before escalating to the specific migraine treatment. The side effects and also the contraindication of NSAIDs, it's very well known. We don't need to speak about it now. So we'll proceed with the specific migraine treatment. We'll start with the triptans. Triptans is the first line treatment to the moderate severe attack from a specific migraine medication. There's seven different available triptans are approved by FDA. The most important one is the most popular one, it's the sumatriptan, which is number need to treat is 2 to 3 if it's being given subcutaneously. But I like, it's barely I see like we use this one in the emergency department. Sometimes it's because the side effects of the triptans because causing cardiovascular and cerebrovascular disease like vasoconstriction, ischemic bowel disease. So there's sometimes little hesitation. Then the second one is the ergotamines. It's very old drug. There is an oral and different formulation of the ergoments. The oral ergoment is less effective. It has a lot of side effects. Also, it's been like avoided and should be avoided in the peripheral vascular disease, cardiovascular disease, and because of severe side effects of vasoconstriction. Also, there is an FDA box warning of the life-threatening peripheral ischemia with a co-admission with a potent CYP3A4 inhibitor. So with a lot of side effects, it's been not used anymore in the emergency department. Now we'll go with the DTANs. DTANs, it's one of the new specific migraines treatment. It is one of the also serotonin receptors. It's called 5-HT1F. It's approved by FDA in 2019. What's the difference between this DTANs and triptans? Because also the triptan is serotonin medication. So the difference between them, it's this DTANs, it's have very low potency causing vasoconstriction. So there is less side effects in case of the patient have any risk factor about like cardiovascular disease or vasoconstriction disease. And it found very well, like the lasmiditan 2 milligrams was very effective and 32%. And as I said, there is less side effect, but there is something to be worried about, like after administration of this medication, there will be temporary driving impairment. So it will be not advised the patient to operate a vehicle or other machinery at least 8 hours following the drug intake. The Giptans. So the Giptans is the last one of the specific migraine medication and one of the new. It is an CGRP receptor antagonist, one of the fundamental neuropeptides that's been found in the migraine attack. The first one, first Giptan, it's abrogeptan, was approved also in 2019, and it found to be effective in 100 milligram, 21 patients. And there is another one, rimigeptan, it's also affected 75 milligrams in 21%, 2 hours pain-free. Also, the good about the Giptans is also less side effects, but it needs to be used with the caution in the patient who's using the medication in the CYP3A4 system, breast cancer resistant protein, and P-glycoprotein only inhibitors, because it's interfere with the elimination of the metabolism of the of these drug and inflammation, and may increase the time, the half time of the drug, and we may have another side effects from these drugs. So antiemetics, what about them? Like, because it's one of the also mainstay of the treatment and migraine attack. So it's recommended to be used as an adjacent therapy, but the Canadian Headache Society, they said they can be used as a monotherapy, like the prochlorperazine and metoclopramide. So now we'll go to the best level evidence. Both of the American Headache Society and Canadian Headache Society, they agreed in 3 lines of treatment with the strong evidence. It's the acetaminophen, the NSAIDs, and the triptans. But they have some disagreement in the level of the evidence and other type of analgesia. What about the Canadian Headache Society? They have a good systemic review, very comprehensive, and recommendation about the treatment of migraine in the emergency department. And this is just like this slide explain or concise the study, the recommendation of the study. So the best and the first one, it's the prochlorperazine intravenously. It's this medication, we don't use it usually in the emergency, but it's very good medication for the migraine. The reason behind we don't use it in the emergency department, because it's very expensive drug, and we have some other option which is also have almost similar effect with less expensive, like metoclopramide. The second option, we don't have the lysine acetylcysteine acid intravenously here in Canada. So if you notice that the metoclopramide, comes in the recommendation above the sumatriptan subcutaneously. This is the recommendation on the Canadian Headache Society. I sorted out if there is another studies that also have some kind of comparing between the metoclopramide and the sumatriptan. So I found something like studies from 2005 to 2020. There's some of the studies, they have some small sample size, some of them single center study, but all of them, they agree that the metoclopramide is equal or little bit superior to the sumatriptan subcutaneously. But always there is some kind of worrying or concerning about the side effects of metoclopramide and the tardive dyskinesia. So there is a good also study was done on Sweden, talking about the metoclopramide and specifically about tardive dyskinesia in the gastroparesis patients. And this is systemic review of articles from 1984 to 2018 about the long use of metoclopramide in the gastroparesis patients for 1 month, 3 months, and 2 years. And they found that there is rare side effects that could happen in the patient with the long-term using of the metoclopramide. Tried to look if there's any study to have if they have any tardive kinesia side effect if they're with a single use or twice. I didn't find any study, and maybe I find a little bit of case report here and there saying 1 dose in the pediatric age, but there is no significant or something said it could cause the tardive dyskinesia with a single dose. So if it is rare with the long use of metoclopramide, I would say it could be extremely rare with a single use. Also, the cephalagia, they said that, however, overall, the evidence of the efficacy of metoclopramide outweighs the risk of the extrarenal side effects in the majority of the patient. So I wouldn't be like hesitating to give a metoclopramide for the patient, like for the side effects, if it's really working. Now we'll talk about the neuromodulation device. This neuromodulation device, it's been studied to have some, it's been studied for a while for treatment for an acute migraine and also for prevention of the migraine. It's a kind of devices they put like with direct contact to the skin, and they send some electrical and magnetic signals, and they affecting the pain pathway on the brain. It's not like that. This is actually what is the neuromodulator devices. But is it effective or not? So the devices and the implanted devices, it's very like highly controversial and has show little benefits. So benefits of neuromodulation might be also limited to the short term, but still insufficient data on the long term. So we are like interested in the short term. So still there is it's highly controversial and show low benefit. So I wouldn't bother like myself or the patient now to speaking about these devices. Now we'll move to the pregnancy and breastfeeding. So in the most of the women with a migraine, the pregnancy is associated with the attenuation of the migraine. As such, treatment might be unnecessary for some during the entire pregnancy. So always the first line, it is paracetamol. NSAIDs should be used with a caution, because in the third trimester, if the patient has some kind of risk of abortion, or so the NSAID might increase this risk, even if the lady doesn't have any risk of the abortion, but the NSAID itself may increase the risk of the abortion. The other thing, it might affect also the fetus kidney. So for that reason, I would say like we'll use it with a caution. What about the triptans during the pregnancy? Has not been well documented studies reporting safely and data about the support use of the sumatriptan. So I would like speak with kind of specialist about the triptan treatment with the neurology maybe. And there is no other acute medication be recommended. So with the breastfeeding woman, the paracetamol is often a good drug. Ibuprofen and sumatriptan is also considered safe in the breastfeeding. I ask myself, if we are using metoclopramide like for the migraine, it's working very well, why would you shouldn't use it in the pregnancy? Because is it part of treatment of nausea and vomiting with the pregnancy ladies? So I looked up if there is any risk factor we can having in congenital malformation. So there is a good Denmark study which shows there is no significant increased risk of major malformation. And also went to the up-to-date, I found that there is also it's being used 5 to 10 milligrams intravenously for 6 to 8 hours. It's very common prescribed for nausea and vomiting in the pregnancy. And there is also meta-analysis of 6 cohort study, including total of 33 first trimester metoclopramide exposure over 373,000 exposed control. And the risk of congenital anomalies is what not significantly increased. So I think it's worth it. We can give it for the pregnancy ladies. We'll move now to the status migrainous. So how we diagnose the status migrainous? So I have been like having some discussion with my colleagues about the status migraines and how we differentiate the status migraines. This is like the patient coming like 4 days of headache, something like that. But we need to know like how it's like this 4 days was going on. Is it responding to the medication or not? So if it is responding to the medication and the patient will have some relief of the pain and will comes again with another migraine, it is recurrent attacks of migraines. So for status migraines, I would say like it's diagnosed with the both the following criteria. It's unremitting of 72 hours, and the pain and other symptoms associated symptoms are depleting. So what's the treatment option? There is no clear guidelines for status migraines, but there is a lot of treatment options. So Hamda, she's like said, like there isn't a cocktail of a treatment or a triad of treatment. This most likely being used with the status migraines, that to give NSAIDs, metoclopramide, and dexamethasone, or like NSAIDs, sumatriptan, and dexamethasone for status migraines. And the dexamethasone, it's always like about not for the treatment in the emergency departments right now, but it's to use to reduce the headache recurrency after the ED discharge. Now we'll move to the medication overuse headache.
Humaid, I just want to make sure, just so we keep track on time. There's about 3 minutes left.
Okay, so we'll speak quickly about the medication overuse headache. So it's a rebound headache with the analgesia. It's like the diagnostic criteria: headache occurs on the 15 days and more, pre-existing primary headache, and consequence of regular use of 10 days or more than 3 months. So the risk of developing, it's opioids, aspirin, acetaminophen, caffeine, triptans, and NSAIDs. So in order to develop that, the type of the headache, most medications to be limited to less than 10 days per month. So if the patient, we should recommend them to use it less than 10 days because it could contribute to the rebound headache. So what's the option of treatment? We need to discontinue all the medication what the patient is using, and we need to take care of the withdrawal symptoms. And at the same time, we need to bridge the therapy till the symptoms is resolved. So some of them will be PO and some of them will be IV. So I would say that to see the overall of the patient status, if it's having severe headache with a lot of associated symptoms, it might be like good to admit for like shorter stay. And if there's the symptoms it's not that bad, we can discharge him. But if he has some medication who has using, it need causing the withdrawal symptoms, we need to take care of this also with withdrawal symptom. So we'll go back to the questions. So for the first question, so we'll start with the like first line, second line treatment, because it's like simple presentation, and we'll scale the treatment based on that. So for the second question, we'll say like, we'll start with the acetaminophen, but if pain is very headache, I would consider the metoclopramide if there's like normal pregnancy and doesn't like there is any risk factor. For the third one, it's a rebound headache. As we just mentioned a few seconds earlier, we need to know which medication is using this, and we'll discontinue the medication. I would involve the short stay and neurological if the patient needs some like kind of an admission. And this is the end of my grand round presentation. Thank you for your attention. If there is any question.
Thanks, Humaid. Do you guys have any question? Obviously, we see a lot of migraine in the ED, so always a relevant topic. And there were a few comments in the chats
Yes.
Let me look at them here. So Dr. Bake was saying that one of the most missed side effect of metoclopramide was akathisia. And Dr. Guy was saying that we should be careful to give ergot when a patient got tryptin in the last 24 hours, it could increase the side effects.
Exactly.
So thanks.
Thank you.
We're gonna move to our next speakers, who are Dana and Hamda. We'll do their journal club presentation, and then we'll have Rashid, who's gonna present on the top 10 neurocritical care pearls in the ED.
Hello, guys. Good afternoon. So today, me and Hamda are presenting for our journal club, where the paper is conservative versus interventional treatment for spontaneous pneumothorax.
So we'll be starting with a short case. So we have a 20-year-old male who's previously healthy. He's a smoker, however. He presents to your emergency department with chief complaint of sudden onset shortness of breath and chest pain, but there's no clear preceding trauma. His vital signs and EKG are normal. So of course, you grab your POCUS and you find lung points, or you don't have lung sliding, or you have a barcode sign. So you grab you order a chest X-ray with a certain diagnosis in mind, and you see this. So on the right side of the chest, you can see there's a significant pneumothorax. So I'd ask you all, you don't need to open your mic and give me an answer, but go back to your medical school teaching and think of what would your answer have been as the next step. Most probably it would have been something like a chest tube or a pigtail insertion. So this brings us to our discussion, whether conservative management is an acceptable alternative to interventional management for uncomplicated, moderate to large primary spontaneous pneumothorax. And at that time, when the study was made, they were thinking about creating the study, the answer to that question was not very well established in a study. So this is how they did it. So it's a multi-center prospective, randomized, open label, non-inferiority trial. I know it's a long sentence, but it was conducted at 39 hospitals in Australia and New Zealand. So it's a large number. And it was about approximately almost 6 years, between July 2011 and March 2017. A total of 316 patients, 154 to the intervention group, meaning chest tube intervention, and 162 to the conservative management group. So as for the patients, these are the patients who are included, i.e. the inclusion criteria. It's patients who are 14 to 50 years of age and who are presenting with unilateral primary spontaneous pneumothorax of 32% or more using the Collins method. And these are the exclusion criteria. So a previous primary spontaneous pneumothorax on the same side, secondary pneumothorax, basically occurring secondary to another underlying pathology, and coexistent hemothorax, bilateral pneumothorax, tension pneumothorax. The clinical definition is a pneumothorax plus systolic blood pressure less than 90 millimeters mercury, MAP less than 65, or shock index of heart rate over SVP or more than 1 or equal to 1. Pregnancy at the time of enrollment, social circumstances that would interfere with follow-up, because this is an important point of the study, and planned air travel within the following 12 weeks. So I'll just quickly go through the Collins method. This is how we do it. I'll just get my laser pointer so you can see it, right? Yeah, okay. So when we get the chest X-ray, we would see the empty pleura and a collapsed lung. So what do? We would divide it into two halves, the top of the collapsed lung and midpoint of collapsed lung. This would give rise to three regions, A, B, and C. So A starts from the apex of the collapsed lung to the apex of the parietal pleura. And then halfway between the top and the midpoint is point B. And halfway between the midpoint and the base of the collapsed lung is point C. And this is the equation, is the percentage. So we get 4.2 plus 4.7 multiplied by A plus B plus C. Another cheat way of getting this is getting a sum of more than 6 centimeters. So A plus B plus C is more than 6 centimeters in total. And the mean size of the pneumothoraces included in this study is 64%. Okay, so we move on to the randomization. It was the technique that was used is the adaptive biased coin or urn technique. They randomly assigned patients in a 1-to-1 ratio to either interventional management or the intervention management or the conservative management group. So now, all patients on both arms of the study received analgesia, either starting from Tylenol, Advil, to oral or IV opioids, and oxygen supplementation if the SpO2 was less than 92% on room air. So we start with the treatments in the intervention group. This arm had patients who were coming in with a pneumothorax. A small bore chest tube was inserted. 1 hour later, a chest X-ray was done. And if there is lung re-expansion, then the drain was closed, and the patient would continue to be observed for the next 4 hours. If the patient remains stable at that point, at the 4-hour mark, repeat chest X-ray would be done. And if the patient remains stable, if the pneumothorax had not recurred, the drain is removed at that point, and the patient is discharged. This is another scenario where let's say, for example, the intervention group patient had deterioration or, if the pneumothorax had recurred under observation or did not show resolution in the pneumothorax, the stopcock was opened, the drain was reopened, in other words, and the drainage was recommenced, and subsequent interventions were at the discretion of the attending clinicians. We move to the conservative group. So patients who come in with a pneumothorax would be observed for 4 hours before a repeat chest X-ray was obtained. If at that point, if at the 4-hour mark, the patients did not receive supplementary oxygen and they were walking comfortably, they were doing very well, they are discharged with analgesia and written instructions. Okay. For the conservative group, there were certain conditions that would qualify them to be switched from conservative to intervention group. In case of clinically significant symptoms, despite adequate analgesia, chest pain or dyspnea preventing mobilization, the patient themselves are not willing to continue the conservative treatment. Patient's condition became physiologically unstable, and the repeat chest X-ray showed an enlarging pneumothorax along with physiological instability. So after these scenarios are completed, we move on to the next stage, which is the follow-up assessments. These in-person appointments consisted of a chest radiograph if the pneumothorax had not resolved on the previous radiograph, and the structured questionnaire addressing symptoms, analgesia use, and patient satisfaction. And they occurred at 24 to 72 hours, 2, 4, and 8 weeks. And at the 6-month and 12-month mark, they were over the telephone. So what were the outcomes that they were looking at? They were looking at the primary outcome they were targeting is complete radiographic resolution of primary spontaneous pneumothorax as determined by the treating physician, so the emergency physician, within 8 weeks of randomization. So we move to the statistical analysis. The non-inferiority trial, the steering committee, that's the word, sorry, had anticipated that a success rate of 90% in the conservative management as compared to the anticipated 99% rate in the intervention group after 8 weeks would be acceptable to both doctors and patients. So that gives us the number of -9 percentage points that I'm going to be talking about. So they found that based after calculations, they found that 274 patients would be required to detect, would be sufficient to detect that non-inferiority margin. And percentage points and absolute risk differences together with a binomial in non-inferiority test were used for the primary outcome. And the primary analysis was based on logistic regression of complete resolution of pneumothorax cases at 8 weeks. Now, there's an issue, like a major issue that arose post hoc. The research team realized that there would be some missing data in patients who were lost to follow-up after 8 weeks or delayed follow-up after 8 weeks, or missing radiological images. So they treated the data on the primary outcome as missing in patients in whom the 8-week visit occurred after 56 days, and they undertook 2 sensitivity analyses to help determine the effects of informative censoring. In other words, participants who were lost to follow-up due to reasons related to the study, and as missing data as treatment failure.
Okay. So we're gonna go into some EVM concepts that were mentioned in this study. The first concept was the adaptive bias scoring technique, which is the goal of this method is to balance the treatment group and for sample sizes as subjects enter the study subsequently, and the total sample size of the experiment is not predetermined. So basically, it's used as one-on-one ratio for admission on each group in the treatment and the control. So it gives it a more balanced, more equal, equal presentation for both sides. The second concept is the open label, which is a type of study in which both the health providers and the patients are aware of the drug or the treatment that's been given. So there is no blinding, and everyone agrees on the treatment that's been administered. So this study is a non-inferiority trial. And what does it mean? The meaning of non-inferiority trial and the use of it is that the null hypothesis, and it states that the primary endpoint for the new treatment is worse than that of the active control by pre-specified margin. And when we reject that hypothesis, it's at a pre-specified level of statistical significance, it will permit the conclusion of non-inferiority. So when do we use these trials is to demonstrate that a new treatment is better than the assumed placebo in a situation where conducting a placebo-controlled trial is unethical. And it also will provide the new treatment that can offer important advantages over the currently available standard treatment in terms of if it had improved safety, convenience, and better compliance or cost. So the concept of the non-inferiority is that we have to have a non-inferiority margin, and it's the maximum acceptable extent of the clinical non-inferiority of an experimental treatment, and must be prospectively defined. So we have to have the margin before we start the trials. There's multiple ways of concluding that margin. The first method is the 95 to 95% approach, and that's what our study has used. And then the synthesis method. And a justifiable margin for non-inferiority should be predefined in the protocol. So sometimes it's based on the analysis of, sorry, it's based on meta-analysis of other studies in the past. So what is the 95 to 95 method? The purpose of the first 95% in the 95 to 95% method is to calculate the effect size for the control group that gives a reasonable assurance of being no less than the true effect size. And
Dan, I think you are muted.
you can't hear me from the other side?
Now, yes.
My voice is clear, right?
Yeah, I can hear you well.
Because we don't want the echo, so I know my screen is muted.
So do you want, did everyone hear the slide?
I'll explain it more on the other side.
Okay.
So in the 95 to 95 methods, we have to start by calculating something called an M1, and it's the entire effect of the active control relative to the placebo. And this calculation, as I said before, it's used based on a meta-analysis analytic method with data from previous studies to obtain a 95% confidence interval around the estimated difference between the active control and the placebo. So the M1 is the lower limit of the confidence interval, and from that we have it's calculated through the meta-analysis of like previous information, the previous results from different studies, and from that we have the margin of if we get a result that's above that, it's going to be superior. But if we get the results that it's above that, it's going to be that it's favorable to the control instead of the placebo. Okay. And we have to also, there is a smaller margin that is used, it's called M2, and it's specified in order to preserve some predetermined fraction of the estimated active control effect. And it can be interpreted as the largest loss of effect, which is the non-inferiority that or inferiority that would be clinically acceptable when comparing the test drug to the active control. M2 is the margin that we can disregard, or it has lesser effect for the study that we're trying to do. Okay. So as demonstrated here, that the difference between a control and the experimental treatment is less than the margin. This is the, can you see the margin? Can you point that?
Sure.
It's the minus delta.
So here.
Yeah. Is if the result becomes, if it's less than that margin, but it's above the 0, then the study will be non-inferior, and it will demonstrate the non-inferiority, which means there is no difference between the two drugs that are being tested. But if the result of the confidence interval becomes above that margin, then it becomes a superiority. That means the new drug is much more superior than the control one. And if it becomes in the 0, then it's an equivalent. So there is no difference, or it's equivalent in demonstration.
Okay. So 1 second. Yeah.
So in our study, in the PSP study, they used the non-inferior. The non-inferiority was tested by generating the 95 to 95 confidence interval. So they had two confidence intervals that they used. The one, from the interventional group, they had the 99% confidence interval, and from the conservative management group, they had the 90% confidence interval. And from that, because there was no previous studies that can demonstrate or had another clinical intervention or had clinical significance from meta-analysis, they established that the non-inferiority margin would be between these two clinical confidence intervals, and they established that the non-inferiority was -9% percentage point. I have to mention that for non-inferiority studies, as it mentioned here, there is the sample size that needed to have that -9 was 274, and our study had a 360 participants. And for non-inferiority studies to be very effective, they have to have a good sample size and larger sample size, because it can be misleading if they have a lower sample size, and it can show that the drug is it can show non-inferiority if the sample size is not representative and if it's a smaller sample size.
So moving on to the results. So as you can see here, I'll just turn on the laser pointer. Okay, so a total of 2,637 patients were assessed for eligibility. And then 2,321 were excluded due to meeting exclusion criteria, or they declined participation, or even loss of referral to the trial team. So a total of 316 underwent randomization, 154 into the interventional management group, and 162 to the conservative management group. Overall, the characteristics of both groups were very similar. They had a high resemblance, and characteristics on both sides were equal. So the primary outcome that we were investigating is the complete radiological resolution at 8 weeks after randomization. And here are the results. So 129 of 131, meaning 98%. 0.5 in the intervention arm. Sorry. Okay, so 118 of 125, 94.4% in the conservative management arm. So that gives us the -4.1%. And it does meet our 9% non-inferiority margin. If the missing follow-up data is imputed as failure, as you recall, there were patients who were missing to follow up, then conservative management did not show statistically significant non-inferiority. It still fell within the 9%. So the secondary outcomes that were investigated also did not show non-inferiority in the conservative management, actually favoring conservative management outcomes. So patients overall had less adverse events, less days off work, and less decreased surgical interventions in the conservative management group for obvious reasons, because they didn't have a tube in their chest at that time. However, there was a reduction in time of radiographic resolution in the interventional management group. Now, as you can, for obvious reasons, the total adverse effects were higher in the interventional management group, including hemothorax, infections, and even hypotension and re-expansion pulmonary edema. Now, moving on to the discussion. I'm quoting this directly from the study, and I found that it was admirable that they started with this humble line. It says, this trial provides modest evidence that conservative management was non-inferior to interventional management for radiographic resolution of moderate to large primary spontaneous pneumothorax within 8 weeks. Conservative management basically spared 85% of these patients from an invasive intervention, fewer days in the hospital or off from work, lower rates of surgery, and a lower risk of serious adverse events.
So talking about the strengths of the study has a very relevant clinical question and aims to address a field lacking in robust data. It was conducted across 39 centers, which is an impressive amount of centers, including a mixture of rural and urban. The exclusion criteria were applied to try and limit the number of secondary pneumothorax, namely the patient's age less than 50 and its being their first pneumothorax. The sample population covered a broad range of hospitals and can therefore be extrapolated to broader Western world population.
Okay. So for the limitations of the study, clearly we can't blind the study because someone has a chest tube and someone doesn't. And another weakness that was interesting to find, that was interestingly reported, the emergency physicians or the respirologists, whoever was following the image, was more likely to report that it had resolved. And there was an independent group of radiologists who analyzed the images later on, and they were less likely to report it as being resolved. The original statistical analysis did not specify how to handle missing 8-week data. This has contributed to the fragility of the results, and it was tackled by assuming failure or for all missing data. So these are our references, and this is a conclusion of our talk today. Any questions?
Great, thank you guys. I don't see any question from the chat. If so, you guys can maybe.
One question.
Oh, go for it.
Hello?
Yes, go for it.
Yeah, I put it in chat, but were these patients all admitted during this study? Because we've been sending patients home since 1985 with chest tubes in place to speed up healing. And it's better with pigtails. And the other comment I've got is, remember, whenever you see someone with a spontaneous pneumothorax, please tell them they can never scuba dive, because that is a high risk problem.
So it didn't.
No, for the patient who was sent for a conservative management, they only stayed for a day, just to make sure that there was no expansion or increase in their pneumothorax. But the chest tube stayed, I think, 2 days in the hospital, according to the study.
Otherwise, if they did have resolution at 4 hours, the drain is closed and they can go home with follow-up afterwards.
Okay, thanks. It just changes some of the criteria since the admission. Days in hospital was different.
Great, thank you. Rashid, I think we'll be ready for you.
Hey, Anne-Sophie, how's it going?
Morning.
So, do you guys want a break or you want me to go straight ahead?
Do you guys want a 5-minute break or you want to go ahead? This is the last presentation of the morning and I'm sure it'll be good. So I want to make sure everybody's got attention. I think you can go ahead, Rashid, if nobody's begging for a break.
All right, so I'll just share my slides first.
Let's go ahead, they say. Okay. Hamda or Dana, I don't know who's sharing their screen, but you have to stop it so Rashid can do it. Yeah, there you go.
You guys see my slides?
All good.
Okay. So hello, everyone. My name is Rashid, one of the previous graduates of this FRCP Emergency Medicine program. I'm currently doing a fellowship in Neurocritical care at McGill as well. And I'm nearly finished my program. I'll be heading back soon, very shortly. So I was asked to give this talk by Zach, and initially it was supposed to be a top 10, but since I only have half an hour, we cut it short to top 5 only. I selected a few pertinent neurocritical care topics that you guys commonly see in the emergency, and we'll just have a quick discussion about a few points. And if you have any questions or comments, please feel free to interrupt at any time. So first, what is neurocritical care? It's a fairly new discipline that specializes in the care of acutely ill neurologic and neurosurgical patients. And as we know, critical care as a discipline, the general critical care medicine, evolved from the poliomyelitis epidemic in 1950s. And it was defined initially as the need for mechanical ventilation in the form of the iron lung. So since then, critical care has branched out into different sort of subspecialties, and neurocritical care is one of the most recent ones, but there's also cardiac intensive care, renal intensive care, surgical and medical intensive cares, neurocritical care specifically has actually branched out from neurosurgery, and specifically the post-operative neurosurgical units, where they had patients who had intracranial ischemic and hemorrhagic events. Those patients needed a unique set of skills in the form of physicians, neurologists, neurosurgeons, multidisciplinary teams who are capable and well-trained in the performance of the neurological exam, nursing, speech therapists, etc. The typical patient population that we look after include adults and children, although in our unit it's only an adult unit. As I said earlier, ischemic and hemorrhagic brain insults, but we also look after status epilepticus, neuroinfectious disorders like meningitis, abscesses, and encephalitis, and also neuromuscular disorders. And if you try to track the history of neurocritical care, you'll see that so in the 1950s you have the poliomyelitis epidemic, and then there was more science and work done on the stupor and coma. 1970s, research into decompressive craniectomy, barbiturates. You go down to the 1950s when best practices for critical care neurology were first made, and the first trials in cerebral hemorrhage in the form of factor VII treatment. And then in the 2000s, the Neurocritical Care Society was created. We now have fellowship programs. We now have examination bodies and certification institutions. So this brings me to the point number 5, or the top 5 point. Neurocritical care does matter. Does all this branching out, subspecialization into neurocritical care, does it have an effect in patient outcome, hard outcome, mortality, neurological outcomes? And there is a lot of work that was done in this. This is one example. It's a Canadian study that was done in BC by Sekon and his colleagues from Vancouver General Hospital that looked at a population with traumatic brain injury, and specifically severe traumatic brain injury with a GCS less or equal to 8. And so it was a quasi-experimental before and after study where they had just your typical medical surgical ICU setup, and they collected outcomes during this period. So outcomes, mortality, and functional status, and then they introduced a new neurocritical care consultation-based service where the neurointensivist with his or her team, a multidisciplinary team, would round on patients, make decisions with invasive and non-invasive neuromonitoring devices. And they looked at the outcomes after this was introduced. And if you look at some of the markers that we usually look out in traumatic brain injury, like mean arterial pressure, ICP, use of pressors, norepinephrine in the right top corner there. And in the bottom, you have sodium control and temperature. So the dark line would be post implementation of neurocritical care, and the gray line is pre-neurocritical care. And you can try to see the separation there, significant improvement, especially in control of mean arterial pressure, control of intracranial pressure, control of temperature and sodium. But did this actually result in improvement in outcomes? And in fact, it did. There was 38% favorable neurological outcome in the post-neurocritical care implementation model. And they used the Glasgow outcome scores measured at 6 months by phone interviews, compared to only 9% before the implementation of the neurocritical care consultation service. So that's a single center trial, quasi-experimental study. This is a literature review based on a very heterogeneous patient population, including patients with ICH, subarachnoid, ischemic stroke, and subarachnoid, I believe. So, if you look at so this is a measure of death, and if you look at the pooled outcome in the bottom, the odds ratio is less than 1. Same thing, even better, size of improvement for favorable outcomes, and you can see it in the bottom. It's about 1.5 odds ratio. So overall, I think there is a benefit for these patient populations to be looked after in a neurocritical care setup, as opposed to a general or mixed neurocritical critical care environment. So consider that for your next referral for a patient with a brain insult. Number 4, I thought about talking about anticoagulation in general, but I'm pretty sure that you've all discussed it ad nauseum. We'll switch gears to antiplatelet reversal here. So anticoagulation, we know it very well. It's well associated with the risk of hematoma expansion, mortality, and poor neurological outcome. We know about the interventions, the reversal, the Variplex, the idarucizumab, and Dixanet alpha. And we've become, as emergency physicians, very comfortable with the use of these medication for controlling hemostasis in hemorrhagic complications. Antiplatelets, however, in general, have a less clear association with outcomes when it comes to intracranial hemorrhage. And for that reason, reversal antiplatelet-associated ICH is less pertinent, has drawn less interest by academia in general. The reversal is usually the form of platelet transfusion to replenish the dysfunctional platelets, which are blocked either permanently or non-permanently by drugs like aspirin, Plavix, ticagrelor, and also DDA, VP, or desmopressin, which is used to increase the endothelial release of factor 8 von Willebrand multimers, which subsequently promotes platelet adherence to endothelium and improve clot formation. So this is one of the landmark studies in acute neurology. It's called the PATCH trial, done in 2016. And it looked at a patient population of spontaneous intercerebral hemorrhage and platelet transfusion compared to standard care according to the Brain Trauma Foundation guidelines. And it's a phase 3 trial, open label, randomized trial. And if you look at the outcomes, you'll see that the MRS 012, which usually is regarded as good neurological outcome. If you look at the standard care group, there was actually there's actually more sort of a better outcome with standard care as opposed to the platelet transfusion group, which is about, if you combine MRS 0, 1, and 2, it would be 9% compared to 17% with standard care. Surprising result, honestly, and this has led to a change in the guidelines in the Neurocritical Care Society guidelines, which was against the use of platelet transfusions in spontaneous intracerebral hemorrhage. And so the other agent that we use sometimes is desmopressin, which been shown to demonstrate improvement in platelet function in healthy patients who are on aspirin, and also shown to normalize hemostasis in uremic patients who are undergoing surgery. Also some parallel similar results in cardiac surgery as well. It's a fairly benign medication, can have some side effects like peripheral edema, natremia, facial flushing. And this is something that we can use in emergency in select population, especially if they're going to the OR or if they're getting platelets and are going to the OR. This is something that we can give at doses of 0.4 micrograms per kg. So consider giving desmopressin in some cases if you feel that the risk outweighs the if you feel the benefit outweighs the risks of hyponatremia, peripheral edema, and basically volume overload. Number 3, so we're shifting topics quite rapidly here, and now I'm going to talk about TXA, and my proposition is that TXA is not a wonder drug, and it certainly felt that way after the CRASH-2, which is the study that looked at tranexamic acid effect on death and vascular occlusive events in patients with major trauma. And after that, so CRASH-2 was a really huge study, more than 12,000 TBI patients with GCS of 12 or lower, and they compared TXA given within 3 hours to standard treatment. And what they were able, the result, the main outcome was the TBI-related mortality. And they managed to get a relative risk of 0.94, but it was not statistically significant. However, if you look at the mild to moderate GCS TBI with GCS of 9 to 15, there's actually an improvement with a relative risk of 0.78 that is statistically significant, and also in patients with intact pupil reactivity, where both pupils are reactive, and the relative risk for this subgroup is 0.87. However, the study was not actually powered for this group. And if you look here, this is how the study was presented by the people who organized it. So there on the top, you have the number of patients, countries, and hospitals, and they claim that TXA could save 1 in 5 people, when we know that the study is not well powered for this effect. And on the right-hand side, this is an adjustment for the poster done by Ken Milne from the SGEM, and it basically corrects the overstated statements. So on the right side, he says results from a secondary analysis of an underpowered subgroup, and instead of 1 in 5 people who were saved, he claims that absolute reduction was 1.7%, which is actually true. And in the bottom, the primary study outcome, no statistical difference in head injury death within 28 days with TXA compared to placebo. Does this mean that TXA is completely useless in intracranial hemorrhage, I don't think that's fair. I think it's still something that we should consider, at least in patients in moderate, mild to moderate traumatic brain injury. And of course, we have to think about the thrombotic complications when we make decisions about treating patients with tranexamic acid in this group. So there's also similar studies done in a population of spontaneous intercerebral hemorrhage. So on the right side, that's the TIC2 study. And again, no significant improvement there in outcome, in functional outcome. And on the left-hand side, it's another study that looked at outcomes in subarachnoid hemorrhage when tranexamic acid was given ultra early, so within 3 hours.
Was that?
And there was no change in outcome when tranexamic acid was given ultra early. Okay, so down to number 2. So blood pressure management in non-traumatic ICH. Again, this is something that we've been discussing thoroughly. And we'll go straight to the guideline recommendation, which is this is the Canadian recommendation. And this comes from the studies that came out from 2013 to 2016, namely the INTERACT-2 trial and the ATTACH-2 trial. And those two studies compared intensive blood pressure lowering for spontaneous intercerebral hemorrhage compared to liberal targets. And these were usually dichotomized as a systolic target of 140 compared to 180. And in the 2013 study, the INTERACT-2 trial, there was, so the intensive blood pressure lowering was not worse, did not lead to a worse outcome compared to liberal blood pressure targets of 180. And there was no side effects of lowering blood pressure aggressively. On ATTACH-2, however, they did a similar design, same study, although they used only nicardipine in their study exclusively. And again, there was no change in outcome. However, there's more renal adverse events in the intensive blood pressure group, where blood pressure was lowered more than 140 systolic. And if you look at the Canadian stroke best practices, they recommend for systolic blood pressure lowering to a target of less than 140 relative to a target of 140 systolic. And it's a level, evidence level A. This is not exactly what we do at the neuro. We actually, we usually receive the patients a few hours later after they have had the initial resuscitation in the emergency. As you know, hematoma expansion is a very front-loaded process where most of the hematoma expansion happens in the first 2-3 hours. And that's why the role of emergency medicine is extremely important to lower blood pressure and specifically avoid hypertension and extreme hypotension, which is equally bad because when you do that, you can actually reduce the cerebral perfusion pressure and lead to ischemic complications. So as much as you can, stick to that 140, 160 blood pressure targets in spontaneous intercerebral hemorrhage. Ruptured aneurysms causing subarachnoid hemorrhage is a slightly different game because when you drop the blood pressure so aggressively, you change the mechanics of blood flow through that aneurysm, and you can disrupt clot formation that might be actually saving that patient. So best is to before the patient is coiled, is to control the blood pressure around the same targets, 140, 160, but it's very important to avoid significant fluctuations. The blood pressure targets can be relaxed after the aneurysm is controlled with a clip or an endovascular coiling. And we're down to the last one, number 1, and I called it the old timers brain tale. And this is basically talking about a hyperacute stroke. So if we look at the history of stroke management, back in the days, stroke patients were assessed in emergencies and admitted to sort of non-intensive care units because there were no options for them. There was only the aspirin, dipyridamol, and supportive measures only. And then the 1990s, the NINS trial came out and promoted the use of TPA. That came out with a lot of resistance as well, especially when a reanalysis of that trial showed a fragility index of 2 or 3. But then more trials came in support of TPA for acute stroke, but many other trials also did not show an improvement and showed increased risk of complications. And within the emergency medicine sphere, there's still a lot of criticism of the evidence-based medicine in acute ischemic stroke management. For mechanical thrombectomy, it's not the same. 2015 was a great year for mechanical thrombectomy when all the 5 main trials or the Hermes collaboration, the first 5, Mr. Clean, Escape, Extend IA, Swift Prime, and REVAS-CAT, and proven improved mortality and functional outcome compared to TPA alone. And the overall number needed to treat when that systematic review was done was 2.6, so really excellent intervention. And we try to offer this to our patients as much as we can. Initially, patients were recruited with a time window of up to 6 hours. But then after that, perfusion, CT perfusion imaging was brought into the equation. And basically, this is a modality that's based on CT angiography. And it has multiple sequences. Well, just to simplify things, I'll explain a couple of them. So on the in the middle there, in the middle of the screen, you have CBV. So that's cerebral blood volume. And on the bottom, you have MTT, which is mean transit time. So mean transit time is a marker of perfusion. And it correlates very well to the penumbra, which is the area of the brain at risk of infarction. While the CBV, so that's the cerebral blood volume, is a marker of infarction. So the signal that you get from abnormal signal that you get from CBV correlates to core infarct. So the way we use it is we do those 2 sequences on CT angio, and we assess the mismatch between the core infarct and the penumbra, and we make tissue-based decisions to offer mechanical thrombectomy or revascularization based on how much we will be saving by doing an intervention. And on the left-hand side there, you see a very nice big left MCA penumbra with a small core infarct colored in red in the center. So this is a very good candidate for mechanical thrombectomy. By the way, this patient can be anything from 6 hours to 24 hours. So the time window is something that's not extremely helpful for mechanical thrombectomy. However, the tissue-based decision-making is the standard here at the neuro. And I think this will become CT perfusion imaging will become more widely used as more centers open up endovascular treatment units and have more comprehensive stroke services. Here is another example using a software called Rapid. And on the right side, you see the penumbra, which is colored in green and purple. On the left side, that's the core infarct with the CBF. sequence, and you see that there's a Tmax of more than 6 times the volume of the core. So this is, again, another good candidate for reperfusion. So time is brain, not anymore. And we will head more into tissue-based decision-making for acute reperfusion and for reperfusion in acute ischemic stroke. Nowadays, we have more and more physicians that specialize, neurologist physicians that specialize in the care of stroke patients. And this is something that you can share the decision for with stroke neurologists. I think we have another 5 minutes. I have just a bonus slide, which is about airway management and status epilepticus. So status epilepticus is a fairly common event in the emergency. This is one of the randomized controlled trials called the OHCA trial, and it was a comparison trial between 3 agents, second-line agents. So that's phosphonatoin, Keppra, and valproic acid. Looked at the rate of termination of status epilepticus, and also complications, rate of intubation, etc. The reason I brought this trial in this bonus slide, which is about airway management, because of this second study, which is a reanalysis of the OHCA trial that looks specifically at the rate of endotracheal intubation and early neurologic recovery and the relationship between those, and the practice pattern variation in between centers. What they were able to document is that the need for intubation is not usually predicted by any factors other than the hospital, the base hospital that the patient is seen. So there was many hospitals that had rates up to 39% of people with status epilepticus that got intubated, compared to other hospitals where the rate was less than 9%. And when they compared those two patient groups, there was no difference other than the fact that it just went and looked after in a different hospital. I know that status epilepticus can sometimes be an intimidating condition, especially when the patient's been seizing pre-hospital, arrives to you seizing, you start your initial benzo medications, and then you give your second-line agents. However, these patients can actually, especially if you know their pathology, if they're patients who are not, you don't have a strong suspicion for a primary acute intracranial event, then maybe holding off the intubation is the right thing for the patient. The advantage of this is you're going to be able to examine them more closely, more reliably, and also you can avoid the complications of endotracheal intubation. It may be reasonable sometimes to intubate a patient with refractory status epilepticus that is not known to have a seizure disorder and who has an undifferentiated intracranial pathology. So those patients, it's fair enough, but maybe try to have a structure or an approach to airway management in status epilepticus. And I think that's it, my friends. Please let me know if you have any questions.
Thanks, Rashid. That was great. I'm sure there's going to be questions. Actually, I have one. I'll take the privilege to start. This neuroimaging, now that's only available at this point at the MNI, I'm assuming, for the flow studies and.
That's right. So only the MNI right now. I don't think even the SHIM doesn't have it, although the SHIM is a bigger sort of neurocritical care center than us, but they don't have it. They use MRI when they want to make more sort of sophisticated acute ischemic stroke decisions.
And do you think that will be confined in the future to a hospital that have neurocritical care, or that would be a bit more disseminated?
Not necessarily. I think it will make its way, because the latest trials that looked at extended time window for endovascular thrombectomy have mostly used either CT perfusion, which is a fairly quick test. It just needs a CT angio modality plus a software that gives you these images. Compared to MRI, which is less accessible, I don't think MRIs will become more and more accessible. I think it will make its way to even community centers. And again, I don't think we'll be left alone as emergency physicians to make like big treatment decisions, and this can always be made in conjunction with stroke team.
Great, thanks. Any other question? I don't see anything in the chat. I might have missed it. Seems your presentation was almost too clear, Rashid. It was really good. Thank you.
All right. Thank you very much. Take care.
Thank you. Thank you, guys. So this is the end of rounds for today. There is senior teaching with Christian Tuart at 1 p.m., which will be a session of mock orals. So see you guys later. Have a good week.